We are live now.
So welcome everyone today on the World Diabetes Day, and this is a webinar which is being held for the same from All India Ophthalmological Society headquarters. And I would, this is actually the brainchild of Dr. Lalit Verma, our president-elect. And I would request Dr. Lalit Verma sir to say a few words on this concept, and then I would request Dr. BK Naik sir to say a few words.
I would appreciate if President can say before I speak.
Yes, sir. Dr. BK Naik sir, would you open the webinar?
Thank you, everyone. Thank you, Namrata, for organizing this program, and Dr. Lalit for having organized it and giving this concept on this World Diabetic Day. The diabetes is really important because it needs more of awareness. Apart from the consultants, we all know what is to be done. But the other discipline also should know that what are the, because many times you have seen even some of the physicians, mostly physicians, diabetologists at least, they are aware about diabetic retinopathy, fully aware. But the physicians, they are not aware and they ignore sometimes, maybe just in hurry or whatever it is. And whenever they treat diabetes, they don't even refer it to ophthalmologists for retina evaluation. Similarly, even the more important is awareness amongst the population, the public, and especially the diabetic population. They should know, because many times we also diagnose diabetes based on the eye examination first time. And when there is some diabetic retinopathy, then we say, have you tested your blood sugar? They say no. And when they get it tested, it is sometimes 400, 500 that we detect. So that is something which is really, this kind of program and the public awareness program is really very important, and everyone should take it collectively. And with this idea, this program has been organized, and I am sure that this should not end just on the day of whenever we are having Diabetic Day program, but it should be round the year. This message has to be conveyed. So with this, I think I will not take much time, and I'll request Lalit Verma to again say a few words.
Thank you, Dr. Naik, for saying one very important line which you said, which has hit me, is that it's not one day program, it has to continue like this. You see, today, the whole world is observing the World Diabetic Day. The reason I'm saying observing and not celebrating, because I don't think so this is a moment of celebration here. The whole world is observing World Diabetes Day, 14th of November every year. The theme being access to diabetes care, proper access. And even in India, if you see, I today was scanning Hindustan Times, Times of India, at least 5-6 pages are there. All the states, all the towns, all the specialties, I'm sure, must be doing some program or the other on diabetes related activities. And all the WhatsApp groups you see, they, whether Tamil Nadu, Kerala, or diabetes societies are doing something or the other. But most are doing within their specialty. Like most of the ophthalmic societies are also doing program related to diabetic retinopathy or diabetes and the eye. But we at AIOS, being a national body, we thought, and I discussed with Namrata Sharma also, that we at the apex body should do it slightly differently. Because diabetes being a head-to-toe disease and a multisystemic disorder requires, as our president was saying, cooperation from everybody. You see, it, if I keep treating retina, somebody treats diabetes, somebody treats kidney status, neural this thing. But since it's a multisystemic disease, it requires cooperation from all the healthcare providers. In fact, besides doctors, it requires cooperation from other healthcare providers, including the paramedical people also. And hence, All India Ophthalmic Society came up with the idea of having a, like Namrata presented here, a holistic view on diabetes, not only diabetes in the eye, but all views like diabetologists. So we are lucky to have diabetologists with us. We are lucky to have nephrologists, neurologists with us. besides our own team of ophthalmologists who will dwell upon glaucoma, cornea, and retinopathy related issues. Further, AIOS takes pride that we have with us Dr. Santosh Honavar, our editor of Indian Journal of Ophthalmology. You see, Indian Journal of Ophthalmology is one of the few Indian journals in medicine which is indexed very highly on PubMed and is very highly rated journal. And it's a happy moment for us at AIOS that Santosh has taken pains and planned, in fact, because without planning, nothing succeeds. He planned way ahead. I remember in March, April, he started writing letters to all of us, and he brought out a special issue. November issue he has devoted to diabetes. So hats off to Santosh, and we will have a small launch because all our governing council members will be here. Have a small launch of this special issue, November issue on diabetes, and thanks to our editor Santosh Honavar. So with these few words, I'll hand over to Dr. Namrata, the secretary, and Dr. Rajesh Sinha, our treasurer, who have taken all the pains, in fact, to help me in organizing this very nice webinar, Holistic View, to take the proceedings from here. Thank you, Namrata and Rajesh.
Thank you so much, sir, for helping, in fact, for doing this. And we have with us our chairpersons, Dr. Barun Naik, sir, President, All India Ophthalmological Society, Head of the Department of Ophthalmology, PD, Hinduja Hospital, Mumbai. Dr. Lalit Verma, sir, we all have heard both of them just now. President-elect AIOS, Director, Vitro-Retina Services, Center for Sight, New Delhi. Dr. Mahipal Sachdev, who would be joining us shortly, immediate past President AIOS, Chairman and Medical Director, Center for Sight Group of Hospitals, New Delhi. Dr. Harbanslal, Vice President AIOS, Director, Delhi Eye Center, Co-Chairman, Department of Ophthalmology, Gangaram Hospital, New Delhi. Of course, I have with me my very able co-moderator, Dr. Rajesh Sinha, who is the treasurer of AIOS, professor at RP Center for Ophthalmic Sciences and Cornea, Cataract and Refractive Surgery Services. I would request Rajesh to introduce the speakers.
Thank you, ma'am. It's a pleasure to welcome our guest speakers in this wonderful webinar. We have with us our diabetologist, Dr. Preoperative Sethi, who is Associate Professor in the Department of Medicine at AIIMS, New Delhi. We also have with us our nephrologist, Dr. R.K. Yadav, who is not only working as additional professor in the Department of Nephrology, AIIMS, New Delhi, but a very active academician and a very good friend. We also have with us Dr. Avadh Kishore Pandit, who is Associate Professor in the Department of Neurology in the Neurosciences Center at AIIMS, Delhi.
So and, I think,
yeah.
Yes, continue, Rajesh.
And then, of course, we have with us Dr. Surinder Pandav, who is the professor and the head of Advanced Eye Center, PGI Chandigarh, in the field of glaucoma. And we also have with us Dr. Anirudh Maiti, who is a retina expert, a senior VR consultant at Netralayam Hospital and BBI Foundation, Kolkata. We welcome you all in this webinar. And of course, expert panel, I'll request Dr. Namrata to go ahead.
So our expert panel, Dr. Partha Vishwas, Chairman, Scientific Committee, Director, Netralayam Hospital and BBI Foundation, Kolkata, has done a huge amount of work in diabetes when he was the chairman ARC and continues to do so even now. And I think his lead article has been published in Indian Journal of Ophthalmology in this month's issue. Dr. Chitra Ramamurthy, Chairman, ARC, Medical Director, Eye Foundation, Tamil Nadu, Coimbatore. Of course, Dr. Santosh Honavar, Editor Journal of Indian Journal of Ophthalmology, Head Department of Ophthalmic Plastic Surgery and Ocular Oncology, National Retinoblastoma Foundation, Center for Sight, Hyderabad. Dr. Arup Chakrabarti, Editor Proceedings, AIOS, Senior Consultant from Chakrabarti Eye Care Center, Trivandrum, and Dr. S. Natarajan, Chairman and Managing Director, Aditya Jyot Eye Hospital, now with Agarwal Group of Hospitals from Mumbai. He is also our past president. And I now would request Dr. B.K. Naik, sir, President, All India Ophthalmological Society, to launch the Indian Journal of Ophthalmology on diabetic retinopathy. Sir.
Thank you, Dr. Namrata. So I just take this opportunity, and it's a pride in launching this IGO diabetic retinopathy special. Also congratulate Dr. Santosh for coming out with this issue. Thank you.
I think all of us should clap for our writer who has taken all the pains. I would request Santosh to say a few words if he is here. Santosh is here.
I'll just open it. And I think it has all these contents which are there, which are all related to diabetes. I would now request Dr. Santosh Honawar to say a few words.
Santosh?
Yes, sir. First of all, I thank Dr. Lalit Verma for initiating this idea. And it was lucky to have Dr. Nayak launch this issue, because he has been the editor of Indian Journal of Ophthalmology, and he is responsible for bringing IGO to the current standards that it has. And we're already always inspired by Dr. Nayak and the hard work that he has put in bringing up IGO. It's such a fortunate thing that he had to inaugurate this special issue. The whole idea started in March, as Dr. Lalit Verma said. I have left the blue circle slightly incomplete because the access is always the issue with diabetic retinopathy. Access to screening, access to treatment, despite the fact that insulin was invented just 100 years ago. This was on July 27, 1921 that insulin was invented. And November 14th happens to be the birth date of Dr. Banting. That is how it is celebrated. The idea came by Dr. Tara Prasad Das and Dr. Sobha Sivaprasad, who is the editor of the journal I UK. And we have eminent guest editors, Dr. Rajiv Raman and Padmaja Rani from LVPI and Shankaranithala and LVPI respectively. And the person who helped do the hard work was Anirudh Agarwal, currently in Cleveland Clinic, Abu Dhabi. Guest editorial board consisted of Srinivas Sada, Dr. V. Mohan, who's a diabetologist, Dr. GVS Murthy, who is from Public Health Foundation, Rajanarayanan from LV Prasad Eye Institute, Hyderabad, Dr. Rajalakshmi, Kim Ramasamy from Arvind Eye Care System, person, Dr. Lalit Verma, of course, representing AIOS and also in his right as the senior retina specialist in the country, and Dr. T.N. Wong. For the cover page, we looked at many options, but we were very impressed by this mural that was created on the walls of Bank of Montreal in London and Ontario. We couldn't get good pictures of this, so we had to request somebody who is local to take a picture of this and send us, and that adorns the cover page. This was a mural created specifically to celebrate Dr. Banting. And the issue has 15 review articles, 5 perspectives, 1 consensus statement, and 43 original research articles from very diverse groups of Indian authors and international authors out of 208 that were submitted. So the rejection rate was about 80%, despite which we have 350 unique authors who have contributed to this particular issue. This is one of the biggest issues to date. And we could publish it only because IGO is currently online and only limited number of pages are printed, only review articles are printed, and everything else is online, thus saving cost. The impact has been, in terms of viewership, we have already had 200,000 plus online page views, downloads, and a robust alt metrics for this particular issue in the 15-16 days that it has been online, and the printed issue will be sent to the members this week. So I again thank the AIOS Governing Council and the leadership for encouraging IGO, and for Dr. Nayak for inaugurating the special issue, and Dr. Lalit Verma for all the initiative, Namrata for all the help that she always does, and Rajesh for the finance. Thank you so much.
Thank you so much, Santosh. Kudos to you and for this stupendous amount of work, that you have done. And before we start the webinar, may I request, I think I can see Dr. Partha Bishwas. Would you like to say a few words, Partha?
Yeah, thank you very much, Dr. Namrata. And thanks to the initiative taken by the headquarters, our presidents, and the General Secretary and the treasurer. We have this webinar today, and it's, as is mentioned, it's a holistic webinar. So with this hope and this insight that each one of you or each one of us need to contribute so that the diabetes, the curse of diabetes is mitigated. And the crusade against diabetic mellitus carries on, not only in ophthalmology, where we are a very, very visible part, but also in all the other faculties. Thank you very much, Santosh, for bringing out this issue and highlighting to the ophthalmological world that what we need to do and how we need to go ahead. Thank you, Varun Naik sir, for the initiative, and Lalit Verma sir for putting it on the platform of AIOS. Thank you very much.
Thank you, Partha. Thank you for the missing link article, which took so much, which required so much of effort to do, and which finally is there in print. So now we would begin with the program. I would request Dr. Prayas Sethi to give us a holistic on how diabetes can affect the systemic, can involve all the systems of the body.
Thank you, ma'am. Thank you. I would like to thank all of you, the Ophthalmological Society, for this wonderful opportunity. And ma'am, I would like to share my screen.
Yes, please, Prayas.
So I think I'm audible and my screen is visible.
Yeah, perfect.
Okay, so I would like to start with some of the basics, the most important of which is how to diagnose a patient of a diabetes. So HB1C is the classical test, more than 6.5%, or fasting blood sugar of fasting of 8 hours of more than 126 milligram per deciliters, or an RBS, random blood sugar of more than 200 milligrams per deciliter with signs and symptoms, or a 2-hour postprandial glucose of more than 200 milligram per deciliter during an oral glucose tolerance test. So any of the following, if present, we should be considering or diagnosing the patient as diabetes and starting the workup. So we clearly know the types of diabetes, type 1 being the immune mediated, the deficiency of insulin related diabetes mellitus. Type 2 is the classical most common type of diabetes, which is because of the insulin resistance or secretory defects. The other types are type 3 and type 4. Type 3 is the specific types of diabetes like monogenic forms, neonatal diabetes, exocrine diabetes, genetic insulin defects, endocrinopathies. And type 4 is the gestational diabetes mellitus. So multiple pathophysiologies contribute to the diabetes conundrum, and it ranges from defect in the insulin secretion, the incretin effect, obesity related lipolysis, liver related increased glucose production, even brain neurotransmitter dysfunction, decreased glucose uptake in the organs like skeletal muscles, increased glucose reabsorption. So various mechanisms contribute to the pathophysiology of diabetes. So talking about the complications and how does it affect the body, is the most important are the concern in the emergency are the acute complications, which include diabetic ketoacidosis, hyperosmolar non-ketotic coma, and hypoglycemia. Other important ones are the acute infections that can happen in patients who have poorly controlled diabetes, and the perioperative complications that can happen if the diabetes is not controlled during the operative period. Preoperative, perioperative, postoperative period are important periods when complications can happen. So this is poor diabetes control can lead to all these. What are the chronic complications of diabetes? So microvascular, we all know nephropathy, neuropathy, retinopathy. Macrovascular, cardiovascular, cerebrovascular, and peripheral vascular disease are the most common. So, and it also is well known that it is the duration of diabetes, which is the most important factor that leads to these chronic complications. So the longer the duration of the diabetes, longer is the chance of setting in of chronic complications. Yes, blood sugar control is important, but duration is considered to be a more important factor than the blood sugar control. So both the factors are important, the blood sugar control and the duration of the disease. The basic pathogenesis resolves around the inflammation, endothelial dysfunction, advanced glycation end products, vascular effects, circulating free fatty acids, and a prothrombotic state that is created. Now, the effect is not just limited to the systems that we just talked about. It affects almost every organ of the body. The most common and most identified of these being eye, skin, infections, and musculoskeletal complications. So once we have this understanding of the affected organs, what is our target? The target before any, we have to decide the target of HbA1c, fasting blood sugar, and postprandial blood sugar. So HbA1c target less than 6.5% is the recommended target in a stable diabetic population. However, this may vary. Fasting blood sugar 70 to 130 milligram per deciliter, and postprandial blood sugar should always be less than 180. So now this slide shows why and in what conditions HbA1c should be more stringent and in what conditions HbA1c should be less stringent. This is important for all of us to know that all patients cannot have one. This is a tailor-made HbA1c that is required. For example, patients who have risk of hypoglycemia, who have longer disease duration, who have lesser life expectancy, who have severe comorbidities, who have established vascular complications, who cannot give much time to their treatment, who don't have that attitude of well-controlled sugar, who do not have the resources and support system, these people need to have less stringent targets as compared to those who are on this side of the normogram. So starting with the treatment, lifestyle modifications are the most mainstay of treatment in the beginning, though it cannot alone serve the purpose most of the time. So some of the patients have this understanding that now I'll do exercise for 1 month and I'll control my diabetes. That is fine, but with that, the work doesn't end. It has to be supplemented with further continued lifestyle modifications and medications. So some of the common drugs used are metformin, SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, thiazolidinediones, sulfonylureas, and insulin. So talking of the important guideline, the most important thing for us to know is the first drug is always metformin. So metformin along with the lifestyle management should be the first line of management. After that, we get an idea from the patient's history whether he has increased risk of atherosclerotic cardiovascular disease or kidney disease. If it is so, then GLP-1 receptor agonists and SGLT2 inhibitors have higher benefit. If the patient has features of heart failure, SGLT2 inhibitors have higher benefits. If there is compelling need to minimize hypoglycemia, then insulins and sulfonylureas have to be avoided, which are glimepiride and netiglinide, repaglinide. If there is compelling need to reduce weight gain, then we should be using GLP-1 receptor agonist and SGLT2 inhibitors. When cost is a major issue, sulfonylureas and thiazolidinediones become the second choice. So overall, based on this, I would just summarize that metformin and lifestyle modifications are the first line of therapy. Second line of therapy is decided based on the patient's risks: heart disease risk, hypoglycemia risk, weight gain risk, or cost. These factors actually decide what is the second drug. When should be using insulin? Insulin is used when HB1C is not achieved by at least 3 oral hypoglycemic agents in maximally effective doses, or HbA1c is more than 9% at presentation, and there is a risk of glucotoxicity. So acute glucotoxicity can lead to reduced insulin secretion. So that has to be controlled in the acute setting. In the inpatient setting, like in critically ill patients, also we need to use insulin. And when there are contraindications to oral hypoglycemic agents like kidney disease. Apart from this, as we have already said, all patients with diabetes should be having a significant counseling regarding weight reduction, because glycemic control prevents nephropathy, neuropathy, retinopathy. But weight reduction reduces risks of diabetes, hypertension, dyslipidemia, cardiovascular disease, kidney disease, fatty liver disease, reflux, sexual dysfunction, incontinence, sleep apnea, reflux, and musculoskeletal pains. And another important thing I would like to highlight is that all patients should be screened for microvascular complications at presentation, whatever is the presentation, at whatever time is the presentation, whether it is younger patient, older patient, symptomatic for that organ or not. All patients should be screened for retinopathy and nephropathy and neuropathy by a comprehensive examination. Retinopathy should be evaluated by ophthalmologists. Neuropathy has to be evaluated by specific neurological tests, especially monofilament test in the early stages. And nephropathy has to be screened based on urinary albumin creatinine ratio, and then further referral to a nephrologist. Inpatient glycemic management is a specific area where the most important thing to know is that blood sugar target is between 140 to 180 in critically ill patients, and in non-critically ill patients, the target is less than 140 milligram per deciliter. And less than 100 milligram per deciliter should never be there in hospital setting, because there is a risk of hypoglycemia. In the surgical settings, pre-operative period, we need to be careful that blood sugar is well controlled before the patient undergoes for surgery. 140 to 180 is the target again for the pre-operative, intraoperative, and post-operative period. We do not recommend a stringent control of blood sugar, because the excess use of insulin and the recovery period may be accompanied with hypoglycemic episodes. So blood sugar of 140 to 180 is the recommended target blood sugar in perioperative period. Just a word about insulins. It's important to know that insulins are regular as well as analog insulin. In analog insulins, our amino acid sequence is genetically modified, and in regular insulin, it's same amino acid sequence as the human. So basically, they are short-acting, rapidly acting. Short-acting one analog insulin are lispro, aspart, glolicine, and long-acting ones are glargine, detamir, and diglodec. Similarly, in regular insulins, short-acting is regular insulin, and intermediate-acting is NPH insulin. We also have pre-mixed insulins like NPH and regular combination, and lispro and lisproprotamine combinations. But there are some complications that are associated with insulin therapy, and these include hypoglycemia and hypokalemia, and all patients should be monitored for this in hospital setting, and for hypoglycemia in the outpatient setting. Thank you. This is all for my talk. I would like to have any questions if anybody wants to. Any comments and questions?
Thank you, Prayas. I think from Dr. Lalit sir, from our
I think he has done a wonderful job. This is what, in a multidisciplinary approach, this is what eye surgeons should know. The only comment I would have is the preoperative, because we operate so many diabetic vitreous surgeries, and there you see majority of our diabetics in India is a rule that doctor sahab kabhi theek rehta hai, kabhi nahi rehta. So this perplexes the whole issue, because a lot of these surgeries are urgent. Some of them are not urgent, especially if the macula is involved. We want to operate fast. So what should we be doing? That how much control we should insist, because anesthetists sometimes will not take up this issue. Like you very rightly pointed out, 140 to 180. I have kept a target for me as 200 se niche rehna chahiye for me to intervene. And also about the role of anticoagulants, because a lot of these patients are on one or two anticoagulants, and diabetic surgery, even though there are a lot of advances, sometimes tend to bleed a lot. So two aspects, maybe Prayas, you can tell us again about the sugar levels and about the anticoagulants in these patients.
Yes, sir. Thank you, sir. So first is sugar levels. So sometimes, as you have rightly said, that blood sugars are so high, but still we want to operate, it is emergency. In that situation, insulin infusion will be the best bet at that time. But we also need to ensure that insulin infusion may be temporary. So after the patient has come out of the operative period, he still needs to be on glucose monitoring and insulin therapy for some time, because the long-term outcomes after surgery also depend on the blood sugar control, and the complications that can happen, that also depends on the blood sugar control. So I would like to say that insulin infusion should be used wherever required in perioperative period. And second thing is insulin in the hospital setting. If we want to control sugar acutely, patient should be admitted 2 days before surgery, maybe, and then we can control his blood sugar in the hospital and go for surgery. For elective surgeries, we don't need to be. We can wait for other methods and other drugs to act. Regarding anticoagulation,
what should be the cutoff for elective surgeries in terms of HB1C, in terms of random sugar?
So for elective surgeries, less than 140 milligram, 130. The normal target is 70 to 130. But for surgical patients, we tend to avoid any risk of hypoglycemia that can happen during surgery. So maybe 100 to 140 is fine. 100 to 140 milligram per set is the target.
So fasting
anticoagulants?
Sir. Anticoagulants, as such, diabetic patients mostly will be on aspirin sometimes because of the risk of cardiovascular disease. So if surgery is elective, we can wait for at least maybe 7 days for surgery, or we can, in emergency setting, 1 or 2 days of stopping of aspirin is the minimum recommended that is required. For anticoagulation, patients will be on like warfarin or some newer anticoagulants. So we need to stop them before surgery, and we need to have a specific score which is known as the Has-Bled score. Has-Bled score has specific components where the patient is at risk of increased bleeding or not. So if the risk of bleeding is less, then we can probably with a day or two of stopping of anticoagulation, we can consider the patient for surgery. But if the risk for bleeding is high, especially when the patients are old age, patients have CKD and platelet, patients have concomitant use of aspirin. So these patients are at increased risks. So these patients should be considered for delay in surgery.
Okay, that's a very useful thing actually you have told. Yes, Partha Viswas?
Yes, sir. One very pertinent question that occurs to all our comprehensive ophthalmologists is, what should be the cutoff preoperatively? That's number one. And what should we bank on of a diabetic patient? Of the FBS, is it the PPBS, or is it the HbA1c? That's point number one. The next thing is how long should the control, a strict control of these parameters be maintained for an uneventful post-operative recovery?
Yes, sir.
See,
So they are very
Priyas, why these questions are coming up is because if you go to Nirman Bhavan, you see there the cutoff, what has been listed there, I have interacted with a lot of these healthcare administrators, is 200 actually. And therefore, the guidelines which AIOS has published was that blood sugar level definitively, as far as mass guidelines are concerned, mass means pure national guidelines. That those
that was
in fact,
random.
even
That was
random. Even courts में भी ये है कि you see there I know a couple of court cases going on. 200 से कम होनी चाहिए. So that is the reason I thought I will take your expert opinion. And the other set is two things. One is the cataract surgery, which is comparatively a vascular surgery. There's not even a drop of blood coming out. So उसके लिए control, उसके लिए values maybe slightly, I don't know, because there we are worried about the risk of infection. Although risk has come down, because today's cataract surgery wound is 2.2 or maybe less than that. The other type of surgery is vascular surgery, which retina people do, where we have to go very close to the vascular structures. There are new vessels formation and they tend to bleed a lot, especially if there is an angry looking front. Although we do manage, so there are two sets of issues. So I would like both to be addressed from the cataract surgeon point of view. Retina surgeon, you have told. You see, I had this incident where patient was on clopidogrel as well as on aspirin, and somehow it slipped or whatever from everybody's mind. He continued till the day of surgery, and I had a tough time controlling the ooze during surgery. So sometimes this can be very capillary level ooze, sometimes this can be neovascular ooze, which are difficult to control. So that is the reason I think Partha Vishwas is asking this.
Yes, sir. So what I get from the questions is, first of all, the cutoffs. So in this, it is important that we have to have a balance. So risk versus benefit. Now, patients who are old age, who have set in complications like cardiovascular disease, they have kidney disease, they also have higher risk of hypoglycemia. So maintaining their sugar to a very stringent level will be detrimental. So in that situation, we target at least less than between 140 to 180 or maybe 200 maximum. But patients who are like young patients who have no complications of diabetes, well controlled for the last few years, then in those patients, it's better to have a stringent control. Why to take more risk of even in my slightest of infection? So it's the balance between the risk of hypoglycemia and the stringent control and preventing of some of the perioperative infections complications. So this is a thin line that we have to understand on a case-to-case basis. Broadly, what we do is less than 140 or maybe 100 to 140 is for patients who are not at risk of hypoglycemia, and 140 to 180 for patients who have risk of hypoglycemia and in the critical care setting, maybe who are having comorbidities. So one answer is this according to me. Secondly, the targets of in the preoperative and post-operative preoperative period and duration. So in HB1C, the well-controlled blood sugar is said to be 6.5%, which is the recommended American College of Endocrinology guideline. But again, as I mentioned in one of the slides, it depends on, it also varies. For a patient who is 75-year-old, 80-year-old, who has CKD, who is living alone, I would keep a target of 7.5 to 8. For a adolescent, even again, I am going to keep a target of 7.5 to 8 because he's going to miss meals, he's going to be sleeping late, and he is going to binge eat sometimes. So 7.5 to 8 is the target. For a patient who is more disciplined, I will keep a target of 6 to 6.5. For patient who is willing to take drugs which do not cause hypoglycemia, which are costly drugs as of now, like SGLT2 inhibitors and GLP-1 receptor agonists, they are at lesser risk of hypoglycemia. So in those situations, we can keep a lower target. So before surgery, less than 7 is optimum for preventing any kind of perioperative complication. 6.5, less than 6.5, even better. But to weigh on the same side of a patient who is old age, probably cataract surgery and cataract surgery, older patients may also be getting so many times. So in those patients, 7.5 is fairly good enough. And regarding retinopathy, regarding retina, I would say, again, stringent control is better because bleeding risk and all is a major thing. And even poorly controlled blood sugar is independently associated with some kind of platelet dysfunction also. And maybe, so we have to weigh the risk, and blood sugar should be less than 180 or maybe less than maximum by 200 should be the target, and not less than 100 is the important thing. Even less than 100 is not suitable for patients who are admitted in the perioperative period or preoperative period. It's not good to have very, very stringent control also.
Very nicely said, Priyas. Very, very nicely said. Honestly, not trying to pamper, but after a long, long time, I heard a very balanced kind of answer to this question. You see, whensoever we have posed this question to very senior diabetologists, I will not name those people, doesn't look nice. So they have, because they were instrumental in giving us this criteria of say 180 or 200, and hence we incorporate in our guidelines. So what I could comprehend from your this thing is a very, very balanced, knowledgeable kind of approach, that it has to be a risk benefit, and for criteria for elderly who are at risk of, who have already certain CKD and other things, whereas younger people. So I must admire this answer, and we will take it forward, Namrata, whenever we talk, that it cannot be one line. It cannot. Yes, Partha.
Sir, again, we need to approach another question, that is the court of law. So what?
Yes, I was coming to that. So Priyas, court of law may suppose a diabetologist has to say, an eye surgeon has operated a patient who has 190 blood sugar. So will you defend me or will you go against me?
No, sir, I will not go against 190. 190 is not that abnormal that it will definitely cause some harm. But I would have to see 2-3 things in this. First, was there a need for urgent surgery, or it could have been delayed for a better sugar control?
So suppose, let's segregate now. Let's segregate. Suppose it was a cataract surgery, which is never an urgent surgery. Okay. We should wait.
We can wait. So less than 200 is it's a line basically. 180 to 200 is a line where you can. It's not that 180 is very good, 190 is not so good. It's not that. It's a line. So
Priyas, honestly, let me tell you, I was going to, not now, going to a court where 203 blood sugar pe a doctor, eye surgeon was penalized. आपने किया कैसे? So इसीलिए मैं कह रहा हूँ, because you know all these judges and these people, I should not say in this public forum, work at a spinal level, कि वो है तो है, वो आपने किया क्यों 200? So that is the issue we face sometimes in consumer courts also. So you have to help us, or your diabetic association help us, because if we say it depends, that can be taken to any level, or किसी भी तरफ वो खींच लेंगे आपको.
Yes, sir.
So we say it was urgent, okay, क्या urgency? So ठीक है, फिर then we say comorbidities, younger age, binge eating, whatever. They don't understand all these things.
They don't understand.
Sorry to say this, but that is the real world scenario.
Yes, sir, I understand. So I have not read this topic from that point of view, but what I make a conclusion out of it is 200, practically speaking, it won't cause any harm. The chances of causing the harm are very less. But as if I have to say something, I have to give an opinion, I would say, if the surgery is elective, let's wait for at least less than 180.
Okay.
This is about random, right?
Random. Yeah. Random. Fasting 140, below 140 is the fasting blood sugar that can be.
I think that is
fair enough. I think fair enough. With this, I think we should move on. We will take your help maybe in future
EPBS,
once we.
EPBS.
So I think this is fair enough. We were not that close, but we had kept cut off in our guidelines as 200, less than 200. But I think
And postprandial kitna bola Prayas?
Postprandial less than 200 is fine. Random 180 is fine. And fasting less than 140 is fine.
So
but
180
A1C, HB1C?
6.5.
6.5.
6.5 is the stringent,
1.5
is good control. See, there are two. In American College of Endocrinology says 6.5, but ADA says 7. So 6 point something below 7 is must. 6.5 less than 6.5 is something which is desirable. And
so summarizing, I'm saying HbA1c less than 7. We don't say 6.5 or 7.5. We say less than 7 is ideal.
Yes.
And fasting 140 and random 180 to 200.
Yes.
That is the range I think we should stick on. Otherwise, we can keep arguing the whole day about all this.
Yes, absolutely fine.
And the last we move on to the next specialist is about the risk of infection, because we are aware that it's not the incidence of infection is not higher, but the severity of infection in a diabetic is higher.
Yes.
You see, that is, I think, true.
Yes, absolutely.
Yeah, that is true for corneal infections, for any infections for that. Even
I think
for
with this, we'll thank Prayas for the enormous effort we have taken and contribution, and we will I think get back to you, or maybe take your help once we are coming on these guidelines. And I will suggest that you can also help us in doing some amount of homework, especially from the code point of view. Urgent surgery and non-urgent surgery, vascular surgery and non-vascular surgery.
Yes, so sure. I'll go through this and get back with some concrete answers on this. Thank you, sir.
Thanks a lot. Thank you. Yes, Nati. Welcome, Nati. Welcome, Nati.
Welcome, Dr.
I
Nati.
enjoyed as Lalit pointed out, maybe we can have a guest editorial or a guest article from Dr. Prayas.
That is what I said. I will seek the help of Prayas. Maybe I have given him a small amount of homework to help us, and maybe we'll take his guidance further. Thank you, Prayas. Thanks a lot.
Thank you, sir. Thank you.
Namrata.
Yes, I think thank you so much, Prayas, and I think Dr. Natarajan sir has given a very useful suggestion. Once it is there in a published this thing, it becomes. The court of law would definitely, take cognizance of the same. So, Prayas, you have to do a guest editorial on what should be the blood sugar levels for ophthalmic surgeries before and afterwards, and what should be the control. Is that okay?
Yes, ma'am. Thank you.
Thank you, Prayas. And now we move on to the next speaker. Dr. Rajesh, will you please call the next speaker? Dr. Yadav.
Okay. May I request Dr. R.K. Yadav to speak on the diabetes and nephropathy?
Good morning to everyone, and thank you. First of all, thank you to organization team for inviting me as a speaker, and I am glad that everyone is committed to improve the patient care. So Dr. Lalit initially pointed out that diabetes is not a single disease. It is a multi-system disease, and there is the contribution of every department, including from ophthalmology, cardiology, then endocrinology, nephrology. And every department is involved in AIMS. And with Dr. Rajesh sir, we did an international project on the new drug, and the project was very good. So if you see worldwide, the most common cause of kidney disease, it is the diabetes. And second is the hypertension. So diabetic kidney disease generally develops after some duration of time, after 5 to 10 years of the disease. As Dr. Prayas already told that the most important is the duration of the disease. And in the initial stage, there is the only microalbuminuria in the urine, and that is defined by less than 300 milligram per day. And with the time, the albumin or the protein in the urine increases. With increase in the proteinuria, there is the decline in the GFR. In the initial stage of the diabetes, there is the high GFR. It is more than 120 ml per minute. But with duration of the disease, GFR declines. So, in the prevention of diabetes, there are two types of factors. One is the modifiable risk factors and another is the non-modifiable risk factors that are genetic, where there is no control. But in the modifiable risk factors, we can control. In the India, the most common factor in my clinical practice, it is the surplus use of the painkillers. It is the one of the most common reason of worsening of diabetes in Indian setting. And then the obesities, then poor control of hypertension, poor control of lipidemia. These are the main risk factors. So in the risk factors where we cannot act, basically age, sex, race, but in the hyperglycemia, here we can act by the proper control of the sugar, blood sugar, and the proper control of the weight and the adequate control of the blood pressure. These are the most important factors. Then toxins and drugs. Another modified risk factor is the smoking. And smoking, everyone knows, it has multiple effects on the body, including lungs, heart, and then kidney. So we should encourage our patient or counsel more to stop smoking. Then where we need kidney biopsy in diabetic patient? It is very unfortunate that we see first-time patient with diabetes either with retinopathy or with advanced azotemia. So these are a very difficult situation where we are. So if a diabetic patient present with a nephrotic range proteinuria or kidney failure on the first visit without diabetic retinopathy, then there is the absolute indication for kidney biopsy. Or if duration is less than 5 years, but there is nephrotic range proteinuria. Nephrotic range proteinuria, it is defined by protein in the urine more than 3.5 grams per day. Or nephrotic range proteinuria with normal renal function. Or if patient have hematuria with diabetes, then there is need for kidney biopsy. Or if there is a rapid worsening of serum creatinine over short duration of time, like if serum creatinine is 1.5 or 2, or after 3 months, it rose to 5, then this is the indication for kidney biopsy. Then on kidney biopsy, there are basically 4 types of lesion. And mostly in our aims, we find in the third stage or stage 3 or 4th. So it is unfortunate that we are diagnosing very late diabetic nephropathy. Then the care is basically not by only nephrologist, it is care by every department. So it should be comprehensive care by each and every department. And then adequate control of blood sugar levels. Then the most important cause of death in diabetic patient, it is the cardiovascular disease. So yes, there is adequate cardiovascular re-evaluation and the assessment is very important. Then the blood pressure control, then newer drugs, which have the beneficial effects on the kidney as well as on the hearts. So as Dr. Priyas already told, the most important is the lifestyle modification in the diabetic patient. And in the Western world, there is the high protein intake, but in India, protein intake is very low. So in diabetic patients who are not on dialysis, protein intake should be more than 0.8 gram per kg per day. And those who are on dialysis, either peritoneal dialysis or hemodialysis, they need more protein intake. It is 1.2 gram per kg per day. And another issue in Indian setting is that Indians consume a lot of salts. So it should be restrict less than 2 gram per day. And stoppage of smoking and other additive like painkillers. Then in the lifestyle modification, one is the physical activity. There is one score that is metabolic rate. MET score, it is basically ratio of the working metabolic rate to the basal metabolic rate. So it should be more than 3. It should be activity should be, if we define by duration, then it should be more than 120 minutes per week. Moderate activity should be more than 120 minutes per week. So then how to control blood sugar? Another point is from nephrology point of view, initially metformin was contraindicated in the kidney disease, diabetic kidney disease, but now guidelines are clear. We can use metformin safely if GFR is more than 45 ml per minute. If it is less than 45 minutes, then we can reduce dose, not to stop metformin, because metformin has multiple benefits on the hearts, on the weight, on the kidney. So if GFR less than 30, it means kidney disease stage 4, then we have to stop. Then these are the newer drugs, SGLT2 inhibitors. These have the beneficial effect on the kidney as well as on the hearts. So in conclusion, there is no single therapy. There is no single doctor who can cure the diabetes. It is a multiple approach. We need all departments, and we have to rule out non-diabetic lesions in diabetic patient. And most important is the lifestyle modification, then drugs, then patient education is the also important part. So if you see here, most important is the exercise, then nutrition, then stoppage of the smoking, then there is the control of the blood pressure, blood sugar, then lipid management, then the newer drugs. So thank you very much.
Thank you so much, Dr. Yadav. I think that was a very holistic approach on diabetes and the kidney. Anybody would like to ask any questions? Yeah, Partho.
So I think, we can broach this subject with a lot of passion, because as we know from the literature, the kidney disease of diabetes and the eye disease of diabetes go hand in hand. So I think one of our missing links that we really identified in our project of diabetic blindness was our nephrologists, our colleagues who are nephrologists, and their inputs and their pursuance for the patients to get an eye checkup done, if it has not been done already, was very, very importantly highlighted. So I think this is something that should become a rule for us ophthalmologists. Anybody having diabetic retinopathy, we must insist a nephropathy checkup and a consultation with the nephrologist. And I think the vice versa would also be true.
Yeah, I think Dr. Yadav was crisp to the point. This is what we would like to hear from a nephrologist. What we can consume, because beyond that is beyond our mental comprehension. Only two questions, Dr. Yadav, which as a retina person comes to me, is a dichotomous opinion which we keep hearing. If I have to do a fluorescein angiography, a lot of people would say एक nephrologist का opinion लेके आओ, because I for one for now 2 decades or more than that have not been taking any opinion from nephrologist for doing an angiography, because we inject sodium fluorescein dye, which is 2 ml we inject, and we do this angiography. And when I was in RP center, I was a additional professor there, and we were not allowed to do angiography without. So later I learned in these patients is not actually required. So one opinion on that, because still I see even at my center for sight, a lot of people still write nephrologist opinion if it is for kidney disease evaluation, but not for angiography. There are two things. The second is about we as stupid people, we still write kidney function test, serum creatinine and blood urea, which I think should go into oblivion once we are talking what Partho was saying as kidney and eye retina going hand in hand as far as the blood vessel affection is concerned. So I think what we should be ordering is what you rightly said is a 24-hour urine sample for microalbuminuria rather than blindly writing, because I see all the ophthalmology writing KFT, blood sugar, HB1C, all these things, or lipid levels. So from your talk, it became very, that was a very good learning point, that microalbuminuria, 24-hour urine sample, less than 300 if I heard correctly, you can correct me. So these 2 points I would like you to emphasize. One is angiography, second is what kidney function test should we be ordering from our point of view.
You are absolutely right. With dye, there is only one side effect. That is because of poor kidney excretion. There may be more duration of yellowishness of skin with the dye. There is only side effect, not adverse effect. Otherwise, there is no contraindication for fluorescent dye. And there is.
So that is wonderful, meaning thereby for angiography, we should not, for evaluation of kidneys, that's okay. But for angiography, we should not be referring. And we can tell the patient that there may be slightly more, stress on this skin or this thing.
Yes.
And the second question was about the kidney function test, which, as is still, I admit, stupidity on the part of ophthalmologists. We blindly write kidney function test. We should always pay attention to the 24-hour urine microalbuminuria, less than, you said what, 300 milligram. Is that correct? Or?
But in Indian settings, sir, you will find many patients who have serum creatinine 5 or 6 at the eye examination. There is defect in the vision. On routine testing, you will find serum creatinine 5, 6, 7, 8.
Yeah.
So there are multiple cases where we can find advanced kidney disease. Those who
that's okay. That is when the kidney has, when the creatinine gets affected much later compared to microalbuminuria. So for as a patient, there are a lot of variety of patients which we get. So microalbuminuria at least should be emphasized more than the and eGFR should be emphasized more than the routine GFR. Welcome, Chitra Murthy is here, our chairman ARC.
Hi, Chitra.
So if you heard, you can ask.
That Calcutta webinar
Yeah.
of the one which Swati doesn't.
Of the EVA.
Of the EVA. It's slipped my
You remember EVA webinars more than the non-EVA webinars.
So Maiti, you had any comment or question?
Anirudh, yeah.
We have been using this anti-VEGF injections quite frequently. Recently, this controversy has come, and from the few nephrologists says that it's contraindicated to give anti-VEGF in a nephropathy patient. So what's your take on that? We are a little bit confused whether it should be a mandatory clearance from the nephrologist to give anti-VEGF.
Sir, if you see history of VEGF, it is first you will see in the eclampsia, pre-eclampsia, it is the causative factor for kidney disease. So there are few studies which say there is worsening of kidney function with time with VEGF. So there is not a lot of data, but I will say, yes, it is not absolutely safe.
No, question that you see literature, because today they're having some articles, as Dr. Matthew was saying, who are, I don't know, unnecessarily scaring ophthalmologists by you cannot give without this thing, kidney.
No.
Because I have read 2-3 articles where Matthew, they have scared the people so much. You see, how come suddenly, you see, anti-VEGFs I have been using for more than 20-25 years, and never came the input from nephrologists regarding that I have to take his clearance.
Sir,
but for last 2 years, Matthew, these articles have scared me shit out of it, that you see nephrology wale ko opinion lena. तो उसके बारे में याद बताना.
Sir has commented that the kidney has deteriorated due to frequent anti-VEGF injection. So that is a concern.
So उसके लिए अगर I know there is some evidence, but as Dr. Yadav was saying, data is coming up, but as of now there is no concrete, solid by a very high guideline of nephrologist or एक international जैसे ADA ने बोला ना, जैसे ऐसा कोई बहुत बड़े group ने बोला नहीं है. There have been few reports and there have been few consensus statements also, but I still am waiting for a national body or a क्यों Yadav?
Basically, sir, with the fluorescein dye, we are doing a thesis which was started last 6 months back with Dr. Nair. So with Rajesh sir and madam, we can plan a randomized trial with these VEGF.
Yeah. वो मेरे ख्याल से थोड़ा सा आप लोग homework करो, because that is because anti-VEGFs, you see, Dr. Yadav, more than 30,000 injections are given, which I am aware, in this country every day. Maybe I'm wrong, maybe it is underestimate, but I am aware 30,000 injections per day of anti-VEGFs again, and I'm not sure 30,000 consultation nephrologist तो नहीं होता.
जी.
So,
So
Dr.
उसको थोड़ा
Yadav,
homework करना पड़ेगा, Namrata.
yes, sir. Dr. Yadav, there is a question from the YouTube. When we should operate in a patient undergoing dialysis? Suppose you have to do some surgery for a
Very
patient
good.
on dialysis. When do you propose we should do the cataract surgery?
Thanks for nice question.
Yes.
Basically, if patient is on dialysis, then we have to give preoperative 2 or 3 dialysis, and then we have to monitor 2 things. One is there is any fluid overload. If yes, then we have to do more dialysis. Second is we have to assess coagulation parameters. In kidney disease patients, parameters are deranged. So we have to check for PT with INR. If these are normal with dialysis and patient is not in fluid overload state and serum creatinine is less than 7 or 6, we can easily operate.
Yeah.
Basically fluid overload, azotemia, and coagulation parameters. These are the 3 parameters we have to look for before surgery.
Yeah, basically, sir, we need a nephrologist clearance who will look at these 3 parameters, and then we can go ahead with it.
I agree with whosoever asked this brilliant question, Namrata, on YouTube. But
Yes,
practically, what I do is, honestly, you see, I operate a lot of this retina surgery on dialysis patient. In fact, if I see all the retina surgery in diabetics, at least 20% or maybe are on dialysis. And my take is that immediately after the dialysis, I operate, or because dialysis generally 2 or 3 times in a week, 3 times in a week. So in between, you have to operate, because that is the best time for these parameters to be normal or near normal.
I think these are also the patients, even if it's a cataract surgery, we need to have a standby anesthetist, because some of these patients can develop a pulmonary edema if they are not well assessed.
Yeah, Chitra, because I think Yadav said that fluid overload, 3 parameters he has told us. So you have azotemia and fluid overload and this creatinine coagulation parameters. So I think, thank you, Yadav. Any other question, Namrata, from YouTube or Facebook? Or
this was the question, sir, that was there on the YouTube.
So we thank Dr. Yadav for his great inputs and very precise and pinpoint take-home messages. But one homework, see, where we need some more help from you is anti-VEGFs, what Dr. Matthew was saying, anti-VEGFs vis-a-vis nephrologist consultation.
We will plan a study within 1 or 2 weeks with Madam Namrata ma'am and with Rajesh.
Perfect.
I think with this, we thank you and for joining us.
Thank you, sir.
Namrata, you can take this forward now.
Yes, so we come to the next part of our webinar, and that is the neurologist's viewpoint on diabetes. Dr. Avid Kishore Pandit, again from All India Institute of Medical Sciences, New Delhi, who's going to be talking about it. And as we speak, I would just like to draw everybody's attention to the YouTube numbers, which are soaring higher because of the content, and there are again a lot of questions which can be taken up after the talk. Dr. Avat, you can share the screen, please. I think you will have to first. Okay. No, the PowerPoint is not open, Dr. Avat. I think you'll have to first open it and then share it. Your folder is showing.
Avat, what I say is you close this, share ko close karke, first open the PowerPoint and keep it near bar mein, and then share. Abhi isko band kar do.
I have opened the PowerPoint now.
No, this first you have to unshare this.
Stop share.
First stop share. Now open the PowerPoint first. उसको फिर नीचे वाले बार में रख के. Then press the green button of share. And once you press green button, वो share के 3-4 ऑप्शन PowerPoint दिखेंगे उसमें.
Is it now visible?
No. Again, we are there only.
Why it is happening?
Anand,
Sorry.
can you guide him, please, Anand? और ममता ये एडमिन वाले हैं.
हाँ sir. Dr. Anand, can you please? Can you, Awadh, can you open your PowerPoint on your this thing? Now it is okay. Open it on your laptop first.
Yeah, I have opened it. Now I am.
उसको मिनिमाइज कर दो. ओपन करने का मिनिमाइज कर दो उसको.
Then I am clicking on share.
फिर इसमें तो एक दिखेगा
green button.
Now is it visible?
Yes. Perfect.
Thank you, sir, for this technical issue. I never thought it will happen. Good morning, everyone, and I thank you, especially Dr. Namrata and all the Ophthalmological Society. And thanks, Dr. Lalit, sir. And I would more rather focusing on diabetes. I have a very specific presentation which really overlaps with ophthalmology, and we really get good help from our ophthalmology colleagues. So, am I audible?
Yes. Please continue.
And so, just I'll start my presentation, and my presentation is it always diabetes or it is something else? So I will start my presentation. So this part I would not want to go in detail about the macula and optic nerve head, but as I think all the audience, they are very clear about all these points of having fovea, macula and optic nerve and the blood vessels. Now, we know what is the internal carotid artery, which starts after bifurcation of common carotid artery. And this is the internal carotid artery, which supplies towards our eye through the ophthalmic artery. And once this ophthalmic artery, then it supplies through the various branches into the optic nerve and into the retina and the other parts of the eye. And ischemic optic neuropathies are those patients who are more than 50 years and there are posterior ciliary arteries. They suffer through atherosclerosis, vasculitis, and hypoperfusion. And AION, that is anterior ischemic optic neuropathy, they have disc swellings more common than the posterior ischemic optic neuropathy. And these atherosclerotic ischemic optic neuropathies, they are more because they are known as non-arteritic ischemic optic neuropathies. Ischemic optic neuropathies, arteritic means we are dealing with some form of vasculitis. And non-arteritic is mostly the atherosclerotic risk factors, those who suffer ischemic optic neuropathies. So mostly the vasculitic part, the commonest we see across is the polymyalgia rheumatica associate or giant cell arteritis. They are mostly elderly, raised ESR, and non-arteritis, they are middle-aged to elderly, and they present with vision loss, and ESR and CRP are mostly normal. And arteritic, the degree of vision loss is usually very severe, and non-arteritic is less severe, but they have significant visual loss. Atherosclerotic risk factors are present here, and in arteritic, the improvement is rare, but in non-arteritic, 30% would improve. And these are the findings which I think ophthalmologists better explain. On arthritic papilledema, there will be cotton wool spots, disc hemorrhages, and the cotton wool spots. And FFA, we can see segmental choroidal hypoperfusion, and in non-arthritic, there can be disc edema, hemorrhages, and in FFA, it can be normal or there can be delayed disc filling. So I will start with a case. I would rather want my ophthalmology colleagues and audience to have an eye, because is it always atherosclerosis, or we blame diabetes or other metabolic diseases towards which causes this changes or the vision loss. So I would rather present a case and then go into discussion. So this is a case I'm presenting as a unilateral papilledema in a middle-aged patient. So she is a 45-year female. She presented to us with blurring of vision in her right eye, one eye, which was of 2 weeks of duration. So the presenting problems, if we go in detail, there was blurring of vision in right eye, which was acute in onset, progressive in nature over the period of 2 weeks. And there was associated history of increase in headache, because she had a history of headaches in the past, which was also increased in past 20 days. And history of generalized weakness was there for about 8 months. And there was no associated pain on extraocular movements. Otherwise, there was no history of transient vision loss. There was no history of scalp tenderness, myalgia, jaw claudication, or antecedent fever, neck rigidity, double vision, or any similar episode in past. And there was no ocular edema or surgery. There was past history of headaches, probably like migrainous, and the patient was on beta blockers and analgesics. There was macroadenoma in non-functional, and she had a history of hypothyroidism and not a known case of hypertension. So if we see the ocular examination on the right eye, which was symptomatic, she had vision of 6/18, and left eye was more or less normal, and there was no RAPD. Another eye examination was normal. And if we see the fundus picture on the right side, there was a disc edema and there was obliteration of the cup. And on the left side, it was more or less insignificant and it was normal. So considering young to middle age, there was 2 weeks progressive history of vision loss. And with this fundus findings and visual acuity, if we see visual acuity was 6/18 on the right eye. So first possibility we kept was ischemic optic neuropathy, non-arthritic, optic neuritis, compressive optic neuropathy, or could be idiopathic intracranial hypertension. And this was I think my ophthalmology colleagues would better understand this, but what have been explained to us is on the right side, if we see, there was a leakage in the disc in the superior quadrant. And at the end, there was significant leakage in the superior quadrant. So, and on the left side, it was normal. And also on OCT, there was superior quadrant of the right eye. It showed an increased retinal nerve fiber layer thickness. And on the left side, it was insignificant. It was normal. And if we see visual field, it was not much conclusive, except for on the right side, there was superior quadrant, but it did not show very significant on this visual fields examination. So patient was evaluated with considering those differentials which I told: ischemic optic neuropathy, IIH, idiopathic intracranial hypertension, and optic neuritis or compressive. So patient showed little less hemoglobin, but there was impaired blood sugar in the form of HB1C of 6.3 and fasting of 124, and we consider fasting more than 126 as diabetes. And postprandial was also raised. So we kept a possibility of right eye non-arthritic anterior ischemic optic neuropathy, because not a very elderly age, 41 years. There was impaired HB1C, unilateral, acute onset, progressive diminution of vision, painless. Points which led us to think was the degree of vision loss, FFA findings, and the visual findings. But what was disturbing was there was no other significant atherosclerotic risk factors. So AION was little difficult to convince. So the patient was referred to us and we did a detailed neurological examination. But on general physical examination, patient was little overweight, otherwise no significant findings. And systemic examination also did not show any findings. So considering those differentials, patient undergoes an MRI and MRI brain, this is T2 axial sequence and flare axial sequence. And this is the coronal sequence of the optic nerve and the chiasma. And this was MR venogram, which was also normal. So patient had the normal parenchymal imaging of the brain. And since we considered ischemic optic neuropathy, so patient also underwent an angiogram in which if we see the origin of the internal carotid artery bilateral, it is normal, there is no stenosis. And intracranial also, there is no stenotic or severe atherosclerosis disease. So patient was further evaluated and patient underwent a CSF examination also. And CSF showed a raised pressure, otherwise of 28 centimeter of water, rest was normal. So here we get confused when we get this impaired glycemia, which is HB1C 6.3, little middle-aged patient, and patient presents with this sectoral visual field defects, degree of vision, which is 6/18. So we kept possibility of AION, but also because of the raised pressure, there was a situation of thinking of it as a idiopathic intracranial hypertension with unilateral papillary edema. So patient was treated with both the measures, mainly the raised pressure were managed using acetazolamide and topiramate, but also was given antiplatelets and statins. And this is the follow-up where we see the best corrected visual acuity got improved from 6/18 to 6/6. And also we see the comparative pictures on the follow-up. We don't see much changes, little disc pallor, which is appreciated at 2 months. Otherwise, this was the finding. So what confuses us is this atherosclerosis, and my point of concern here is this is a case of idiopathic intracranial hypertension, which presents with the ischemic optic neuropathy, and this atherosclerosis, sometimes it can be a silent bystander. That's all. Thank you. Hello.
Yeah, thank you, Namrata. You're
Yeah, thank you, Dr. Awadh. The case is open for discussion if anybody would want to ask anything.
Because my intention was that this diabetes is sometimes difficult to differentiate from these other illnesses. So I little diverted the situation to think away from atherosclerosis, even if there are such situations. But this is open for discussion because there was many overlaps. So I thought I'll bring down to this platform.
So any comments from anybody?
Neuropathy. So neuropathy is something that we definitely do meet as a comorbidity when we are treating our diabetic eye diseases. So how often should we investigate? I mean, at times the patient already has low vision because of different aspects. It could be ischemia of the macula, it could be a cataractus change. So per se, should we investigate for neuropathy evidences or optic nerve disease per se when we are treating our patients for diabetic eye disease?
Yeah, so I think diabetic neuropathy must be investigated. Like if you say there is a diabetic retinopathy, that means the diabetic neuropathy is also set in. So what we say is, if you find neuropathy, that means diabetes has already established for at least more than 8 to 10 years. So that is, and the small fiber neuropathies or the autonomic neuropathies, sometimes they may not be very symptomatic. So that needs to be investigated even if the patient is not having any symptoms in form of sensory or motor deficits. And that is.
So I think
what tests are generally recommended for this small fiber and autonomic neuropathy?
But if there is no optic disc edema and the disc looks normal, and if the fields are normal, why would you wonder for an optic neuropathy? I'm answering Partha's question. If a patient comes to a cataract, and if the disc looks healthy, you will not go through the battery of those tests. If the disc has some pallor or there is some edema, then you have to give extra attention to optic neuropathy changes.
So I think there is a difference, a dichotomy. The thing is, we are not talking only of optic nerve as the nerve only. Exactly. You see, neuropathy could be, there are so many other nerves, no? You see, what
retina is also the nerve set, sir. Retina itself is a nerve set.
Yeah, no, retina is one nerve set. That is one cranial nerve. That is optic nerve. But there are other cranial nerves like 4, 6, and. But what I think Partho was hinting was other peripheral nerves and autonomic nerves. Unka investigation point of view. Yeah. And what Avadh posted a challenge to us that you see whether it is what kind of process is going on based on all the investigations what he has done and what ophthalmologists also did. So there are two different things, I think. So, but Avadh, based on whatever you presented, I think diabetic it was definitely not, because it was two borderline kind of sugars. And the other thing about it fits primarily into the idiopathic intracranial hypertension, because the way it improved from 618 to 6/6 based on treatment with Diamox and dopamide and other supportive treatment, because it does not happen with arteritic or non-arteritic AIONs. Plus the fundus picture, you see anatomically, even after improvement in the infranasal part, there is a structural defect of the what we call a conus kind of picture. So that will remain hypofluorescent because of the anatomical configuration. And that is not ischemia what we are seeing, because even after, you have corrected that 6/6. So if you see that picture, infranasal, there is a different kind of disc appearance. And I thought there is a infranasal conus, what we say anatomically in the optic nerve. And but I agree, at best, based on the CSF pressure and the improvement with Diamox and so fast, it fits into, at best, if I have to point out one diagnosis, is idiopathic intracranial hypertension.
Yeah, and this association of ischemic optic neuropathy is also been found with this papilledema. And point only which made us thought of ischemic optic neuropathy in isolation was the degree of the vision loss. And because not so much of papilledema, and there was a good degree of vision loss, and there was a sectoral leak which we saw on the FFA, and this disturbing HB1C, because we see more cranial neuropathies or peripheral, what we call radiculoplexopathies, in this impaired group of glycemic controls. So not a very frank diabetes, but this borderline, or what we say impaired HB1C, these are also the groups which plays a role into this neuropathy, specifically the optic, third nerve, sixth nerve, and lumbosacral radiculoplexopathies. So that's why this impaired HbA1c is also a red flag. So that's why we kept, so we went ahead with this CSF analysis, and that helped us.
Yeah. Pandav has any comment about this patient? Muted, Pandav.
No, you're muted, sir.
I think they're very, very interesting case. So in fact, I think, and we do get this kind of challenges clinically, but definitely, I think a presentation, one would have suspected of ischemic pathology here, and I think subsequently that was kind of investigated and ruled out. But the diabetes does lead to, as mentioned earlier, peripheral neuropathy, and as you asked, how should be should be investigating these patients at all for autonomous and other effects of diabetes or not, and at what stage? So that kind of we are not very clear on that.
Yes.
Oh, then you take home points for that, because one is that patient with visual loss and AION kind of picture of compressive neuropathy or ischemic present to us, then we seek opinion from neurologists. Apart from that, peripheral nerves and autonomic nerves, do you recommend some kind of referrals, or we should be sending, like you said, whenever a patient of diabetes has more than say 10 years or so, and he has obvious retinopathy, that means by and large neuropathy may be there.
Yes,
so
yes.
What is your recommendation?
Yeah, I would recommend they should be screened for peripheral neuropathy, what we call as triopathies at that moment: retinopathy, neuropathy, and nephropathy. So that case, we need to see all these three aspects. And for small fiber, we do miss these things on our nerve conduction tests. But now we have what we called as autonomic function tests, where we do assess this parasympathetic cholinergic small fiber neuropathic tests. So we do get to know about the small fiber neuropathies. Anyhow, the gold standard for small fiber neuropathy is skin biopsy and do a electron microscopy, but that's also not recommended. Also, the fine filament test, what my one of the colleagues said, that you check for the very fine sensory loss, but that also becomes little subjective. So let's wait for the further investigations, but we do autonomic function tests.
So basically, whenever suppose a patient comes, we refer, or patient comes to you, diabetes, the assessment of autonomic system, that you definitely do.
Yes.
But this fine filament test and obviously biopsy and electron microscopy, you are not doing at this.
Not doing it routinely, unless it is like patients who present with severe sensory, what we call as painful sensory neuropathies. So in that case, we need to prove it, and sometimes we have to treat them with immunomodulation, because these are very disabling. And in biopsies also, we have seen that we call them as diabetic inflammatory polyneuropathies. So we need to treat them, and we need to see for the differentials also, because sometimes malignant inflammatory sensory polyneuropathies are there, which can be missed. So that's why I brought this case also. So don't blame the diabetes. The question answer can be lying somewhere else.
Very nice line. Actually, I like that. You see, presence of diabetes does not necessarily mean that they are immune from other diseases also.
So let's not dispose everything with diabetes. Yeah.
Absolutely.
Yeah.
Good message.
Yes.
Thank you, Avadh, for highlighting this very pertinent issues. Namrata, can we move on?
Yes. Sir, Doctor, there's a slight change in the order of the presentation. I would request Dr. Anirudh Maiti to give his presentation on diabetic retinopathy.
Thank you, ma'am. Is my presentation visible?
Yeah.
At the outset, I'd like to thank AIOS for giving me this opportunity. Well, I will be giving a brief outline on the diabetic retinopathy. As we all know that India has already become a capital of diabetes globally, the prevalence of diabetic retinopathy is also increasing in India. Based on the landmark study of the Chennai Urban Rural Epidemiological Study, the prevalence is 17.6%, out of which 20.8% in the known diabetics and 5.1% in the newly diagnosed diabetics. Now, the basic classification of diabetic retinopathy, along with the non-proliferative diabetic retinopathy, which passes on from mild, moderate, severe, and then progresses to proliferative diabetic retinopathy. On the other hand, the maculopathy, we need to see whether it is a center involving maculopathy or a non-center involving maculopathy. So it depends on the retinal signs, the exact stage of the retinopathy. Now, coming to the diabetes and visual loss, what is the relation? The patients with diabetic retinopathy is 25 times more likely to be blind than non-diabetic patients. And diabetic macular edema is the common cause of blindness in the people of working age group, that is a younger age group, and can develop in both the type 1 and type 2 diabetes mellitus. And 8% of diabetic patients developed DME with visual impairment. Now, coming to the investigation and the based on the theme of this entire webinar, we are most of the time focused on the ophthalmic investigation. We actually forget about the systemic control. So we need to focus, other than ophthalmic investigation and diagnosis and treatment, we need to see what is the state of the glycemic control, what level of the HB1C, the renal profile, lipid profile, and blood pressure color. Simultaneously, we should refer to our endocrinologist for a diabetic checkup and proper control. And it has already been proved that lowering the HB1C reduces the risk of complication. Lowering just 1% of HB1C reduces 21% death related to diabetes, 37% microvascular complications are reduced, and 14% myocardial infarction. So how important is glycemic control along with the treatment of the diabetic retinopathy? Now, this is based on the STENO2 study. There are a lot of recommendation from international association. So if the criteria is kept like this, the chances of the microvascular complications like retinopathy is reduced. Obviously, these are very strict intensive control. So these are just for a recommendation. Just we should keep in mind and refer to the endocrinologist for a strict control, not only diabetes, but also blood pressure and as well as cholesterol. Now, recommended eye examination schedule when type 1 diabetes has been diagnosed, at least after 3 to 5 years, should have an examination, or a recommended follow-up is at least once in a year. Type 2 at the time of diagnosis, and obviously after yearly. Definitely the schedule changes. It depends on the stage of the diabetic retinopathy detected. Now, coming to the dilated retinal examination, the fundus lens and the slit lamp evaluation is mandatory, and as well as the binocular indirect ophthalmoscopy. Fundus photography, what is the rationale behind taking a fundus photography? Obviously, it identifies the stage of the retinopathy. It helps in the documentation. We can compare with the previous pictures. We can actually explain the patient whether your retinopathy is progressing or not, or rather the response to the treatment can be documented. Now, coming to the digital fundus angiography, once upon a time we were doing very frequently, but in fact, a lot of endocrinologists sent to the ophthalmologist saying that a DFA is needed to screen the diabetic retinopathy. Just to mention, this is not a screening tool nowadays. It obviously helps in treatment, or rather guides us in treatment. It gives us a state of the macular perfusion when there is unexplained visual loss. Identification of the neovascularization when there is a confusion when we are not very sure about the neovascularization clinically, and identify the focal or the diffuse lesion. Definitely helps in planning sometimes a laser. The most important investigation tool is the OCT. The rationale is to quantify the macular edema. And we know a lot about the vitreoretinal interface, whether there is any vitreomacular traction, the ERM, or sometimes at vitroschisis as well. It differentiates the different types of macular edema, and the treatment can be planned accordingly. So it guides in the treatment protocol and also sees the response to the treatment. And in fact, the most important advantage of the OCT, it's a very important patient educational tool. The patient can see whether the macular edema is increasing or decreasing with the treatment. Ultrasonography, yes, when there is no view, definitely in a case of a vitreous hemorrhage, we need to rule out whether there's a presence of a TRD or not. In the presence of the TRD, we have to operate as quickly as possible. And if there is no TRD, we can actually wait for 4 to 6 weeks. So diabetic retinopathy, the aims of therapy is two. One is the reduction in the vessel hyperpermeability and leakage in macular edema. Another is the treatment of neovascularization in PDR. So there are some classic indications like PDR with high-risk characteristics and CAC with some extrafoveal leakage. As you can see in this picture, the laser, there's the pre-laser and the post-laser. But definitely, there are other indications where we need to do the laser, especially if there's NVI, or if there is a severe NPDR, but there is high-risk factors like pregnancy, hypertension, renal failure, elevated lipids, or the patient is undergoing a cataract surgery. one eye patient, the other eye is lost due to diabetes or advanced diabetic eye disease, or a non-compliant patient, unlikely to do follow-up. So in a severe NPDR also, we do the laser. Obviously, laser treatment is destructive and cannot restore the vision loss, and that has already occurred. So there was a need for a better tolerated and less destructive therapy. So the role of VEGF came in diabetic. It has been already proved that the VEGF plays a major role in the patients in DR, which mediates active intraocular neovascularization and breakdown of blood-brain barrier. So thus, this new treatment came starting from triamcinolone acetate to Lucentis, Avastin, Macugen, Ozurdex, and now the new medicine, the Peganex. And most of the patients actually respond pretty well with the anti-VEGF. And combined with a laser, it is always, and practically we have to combine with laser at times, but studies has proved that the prompt laser, we can actually defer the laser within 6 months following the anti-VEGF therapy. And in a pseudophakic patient, the steroid also works pretty well and can be comparable with the monotherapy of anti-VEGF. This is another therapy, dexamethasone intravitreal implant, which is done in few pseudophakic patients and patients where the anti-VEGFs are contraindicated. As you can see in this case, in the first 3 injections, there was no response at all. And when Ozurdex injection was given, it responded pretty well. Sometimes with change of anti-VEGF also works. So the first 4 injections was Lucentis, didn't respond much, but when it was changed from Lucentis to aflibercept, it responded pretty well. So some patients do get a better effect when the anti-VEGFs are changed. I think this is something new which should be kept in mind when a little bit of SRF is there, a small intercystic space, or a vitreoretinal adhesions. These are good prognostic biomarkers, so which actually responds better with the anti-VEGF. And the second set of pictures, there's a hyperreflective foci. The more the hyperreflective foci, bad is the prognostic marker. It's a bad prognostic marker. But definitely another thing is there. It is also an inflammatory biomarkers where steroid can be planned. And the last set of pictures are the last cystic spaces with viscous fluid, which is considered to be the bad prognostic biomarkers. Lastly, the indication for vitrectomy. Yes, where the vitreous hemorrhage is not clearing or there's a progressive fibrovascular proliferation. If the tractional detachment is threatening the macula or a combined TRD with RRD, we should plan for surgery. The point which needs to be emphasized that earlier we operate, the visual prognosis is better. Definitely with the latest instrumentation, we do get a good anatomical result, but if it is late, the functional improvement is not that great. So to conclude, we should remember, along with the diabetic, the ophthalmic diagnosis and treatment, we should keep in mind the ABCs, that is HB1C, blood pressure, and cholesterol. And eye examination, definitely the annual dilated eye examination is mandatory. Diabetes with excellent blood sugar control with no diabetic retinopathy also needs an annual checkup. And obviously, depending on the stage, there needs a frequent eye examination. And as we all know, the earlier diagnosis and treatment, it definitely prevents the blindness from diabetes. Thank you.
Thank you, Dr. Anirudh. I think that was a perfect overview of diabetic retinopathy, especially on this World Diabetes Day and in this webinar, which is, which is looking at the holistic effect of diabetes on not only the systems but also the eye. Any questions from?
No questions at all. No questions, because he has summarized it so well actually that even I have no question. I don't think so. On a World Diabetes Day, a better job can be done by a retina surgeon with so few slides and conveying each and everything. Hats off to Mehti.
Thank you so much, Anirudh. Thank you.
So because you see, we can go on and on for retinopathy because that is not the focus. Our focus is a holistic approach. And that's when I spoke to Mehti was a very, brief, holistic, not to miss anything. So he has covered everything about anti-VEGF se leke, Rolocimab, everything he has covered. So therefore I said no questions. Unless Partho will definitely dig out one, but I think he has covered very nicely.
He's covered very well, sir. Very well.
Very well. I think we should move on. Thanks, Mehti, for joining. And the reason we delayed, ophthalmic colleagues was primarily because as a intuition, we wanted to hear more about general things than these things. So thank you for bearing with us.
So next I'm going to be talking about cornea, ocular surface, refractive surgery, eye banking, and diabetes. And just as Dr. Mehti's talk was so perfect and so clear, mine is going to be ambiguous, because we will confess that posterior segment people have done a lot of research, come out with a lot of modalities, the way to treat, but somehow the anterior segment research has not been to the level it should be. And there are a lot of areas which are really, my slide is not sharing, I think.
It came actually, slide did not come, but.
Okay, I'll try again. It is not as, it's not coming again.
We
So
just see the blank screen.
Yeah, it is not as clear as the anterior segment people are.
Even the screen is not as clear.
No. Okay, let me try again. How is it? I mean,
I'm seeing for the first time that.
First time even I am also seeing. It's coming, sir, now.
Yeah. Now it has come. There's slide bhi dar gayi.
So I will be talking, and it is good that we thought about it, because only then I started to see what was actually there as far as diabetes and cornea and ocular surface changes are concerned. Although we did have some idea, there are no financial interest in any of the products which are mentioned in the presentation. And diabetes, in more general terms, can cause dry eye, diabetic keratopathy, diabetic cataract, diabetes and glaucoma, diabetic retinopathy. And there are 5 layers, and I would be discussing in each of the layers and each of the structures which are shown here: tear film, epithelium, Bowman layer, stroma and corneal nerves, endothelium and Descemet's membrane. What are the changes which occur due to diabetes? Of course, most of it is research and may not translate clinically. So if you look at the alterations in the tear film, there's decrease in the tear proteins and neuropeptides. The inflammatory markers are increased. The osmolarity of the tears is increased, and glucose concentration in the tears is also increased, which may be responsible for impaired corneal epithelial wound healing. So this is just a schematic diagram which showed that how inflammatory factors, neuropeptides, metallic elements, tear proteins, all in diabetes mellitus on this half are increased, and this can lead to epithelial defect as well as features of dry eye, which is tear film instability, as well as hyperosmolarity. Now, when you delve more into the research, you find that there are still some changes, some tear proteins which don't change, which are highlighted here, like lactoferrin, albumin, lipocalin, lysozyme, and secretory IgA, but in general, they do increase. And the total glucose levels are about 10 times lower, but well correlated with the blood glucose levels after allowing for the equilibration. And the total glucose concentration also people have seen without diabetes. What is it in the tear film, which ranges from 0.05 to 0.5 millimolars and 0.5 to 5 millimolars for patient with diabetics. So just like the glucose concentration increases in the blood, so does it increase in the tears as well. Now, if you look at the insulin levels, again, it is the same picture as is present in the blood. Insulin levels in stimulated tears of patients without diabetes is 0.2 nanogram per ml under fasting conditions. And when after a meal you check, it increases to 0.6. And there is something which is called as insulin-like growth factor binding proteins, which binds to insulin-like growth factor 1 to activate the cell apoptosis and anti-proliferation. And expression of this factor is increased in type 2 diabetes. Now, lacrimal function lacrimal functional unit also shows dysfunction because of the inflammatory damage which occurs to not only the lacrimal gland, but also to the meibomian gland, to the conjunctival goblet cells. And there is, as was being discussed, neuropathy element, which affects both afferent as well as efferent arms of the tear secretion. So all in all, it does lead to dry eye disease. Now, there is something which is called as diabetic keratopathy, and what are the clinical features or what is the spectrum? So there would be loss of corneal sensitivity, recurrent corneal erosions, dry eye, delayed wound healing, and neurotrophic corneal ulceration. And if you look at the other features also, apart from the ones which have been mentioned, there would also be endothelial decompensation. Now, this mainly occurs because of, like I said earlier, overexpression of cytokines, chemokines, and pro-inflammatory proteins and pro-apoptotic genes. So diabetic keratopathy is actually not a single corneal pathology or a single corneal disease, but encompasses all of them or one of them. Like I said, it is not as clearly defined quantitatively as is diabetic retinopathy. Maybe people have not worked on it enough. And this corroborates very well with the research which has been done mainly in the animal studies to see which nerve fibers are affected, and it is the A and the C nerve fibers of the cornea which have classically been affected. If you look at the epithelial cell density, that is also reduced in diabetes, and corneal Bowman's membrane also becomes thicker, and some ocular pathology which is discussed occurs sooner in the spectrum of the disease than the classic clinical symptoms or the retinal disease. And I think that is what we need to figure out, that the corneal changes occur first or the retinopathy occurs first. And where does these corneal changes fit in? Can we, even before the retina people pick up the retinopathy findings, can we pick up something in the cornea even earlier than that? And then that way it is going to be a better marker, because retinopathy is going to occur later. Now, this is just to show how recurrent corneal erosions can occur, and these will have classically, they will stain with the fluorescein dye, and patient would have features of pain, redness, congestion, and watering, and sometimes these are really painful. Again, DUCE2 report has shown that diabetes is a significant risk factor for the dry eye disease, and patients diabetics have faster tear breakup time, decreased tear production, increased tear osmolarity, and greater rates of meibomian gland disease, as well as blepharitis. Of course, the treatment is only palliative in the form of ophthalmic lubricants, punctal plugs, medications which can be given topically or orally, which would include cyclosporin as well. Then autologous serum, amniotic membrane transplantation, lid closure. And the only drug which has been approved is Senegermin, which is, of course, as of now, not available in India. Now, bandage contact lens should be contraindicated in general. I mean, it's a relative contraindication for diabetics because this can cause infection, and NSH should never be given because of the possibility of corneal melts and the possibility of corneal perforation. There is one study which looked at the use of topical insulin, which improves time to wound healing, and this topical insulin may have a role in future in corneal wound healing. And again, this was an idea which came just now. And as we see the ocular surface microbiome, although predominantly normal healthy corneal surface or ocular surface, you have Corynebacteria, Staph, Streptococcus, Acinetobacter, and Pseudomonas. But in diabetics, you have other organisms like E. coli, Klebsiella pneumonia, and Enterococci. And what is seen is that there's a higher positive culture rates and there's a greater bacterial diversity in diabetics. And you doing molecular analysis, again, different organisms like Sphingomonas and Ralstotonia have also been seen as compared to the healthy controls. And there was one study which said that there's increased risk of acute bacterial conjunctivitis in diabetics as well. Now, if you look at the nerves, I think that is the only thing which can be imaged, just like the retina people do the imaging of the fundus. The only imaging which we can do is of the corneal nerves, and the corneal subbasal nerve fiber length, density, and branching are reduced with diabetics. And this again, the nerve fiber length and the nerve fiber density can be a marker for diabetes, because this is also going to be affected by diabetic peripheral neuropathy and the autonomic neuropathy. But where in it will fit in the entire diabetes spectrum remains to be seen. Now, this is just to show that this is how, when there is no metabolic disease, the nerve fibers will look like, and the density is quite high. But as there is in pre-diabetics, this would decrease drastically. And in diabetes, there is a frank decrease of the nerve fibers. And the apoptotic keratocytes would increase in pre-diabetes and diabetes if you compare it with the state when there is no disease at all. So this is something where we could do research in future. Now, because of the various accumulation of the advanced glycation end products, there are two effects. One is the corneal thickness would increase, even in well-controlled patients with where the glycosylated hemoglobin was less than 7, and duration of diabetes can be correlated with increase in the corneal thickness. Now, in the corneal stroma, again, the biomechanics become better, which is expected because of the accumulation of these glycation products. And because of this, I'm sure Dr. Pandav is going to be talking about it. There may be an overestimation of intraocular pressure, which may lead to a misdiagnosis of glaucoma. Then in stroma, like I said, there are going to be again changes because of the cross-linking that occurs and because of the accumulation of the glycation products. And this was a study where they looked at the peripheral neuropathy severity and found that this was much more in cases of diabetics, and they directly correlated it to the central corneal thickness. Now, as far as the endothelium is concerned, the endothelial cell density would decrease. There would be more pleomorphism, more polymegathism in cases of diabetics. And the duration of the diabetes is well correlated with the endothelial cell density loss, polymegathism, and the pleomorphism. And this test is, I think, again, which can be looked into future, and that is cornea autofluorescence, because this has been correlated with the duration of the disease and the severity of the diabetic retinopathy, as well as the glycosylated levels. And this is something which we can look at in future for research. Maybe corneal autofluorescence occurs much before the diabetic retinopathy also, and can be used as a good tool to look at as a marker for diabetes as far as the eye is concerned. Now, this is just to show that the advanced accumulation of the advanced glycation end products occurs, which leads to release of reactive oxygen species and sorbitol accumulation, and finally stromal edema. Confocal changes I've already discussed, but just to show polymegathism and pleomorphism, you can see that these the cells are showing a change in the size as well as the shape in cases of diabetics. And this is again a study to corroborate the same, which has already been talked about. Then apart from this, even the limbal stem cells will show a change. There's a reduction in the expression of the limbal epithelial stem cell markers. Intraepithelial cystic changes are there. And again, this is something which has really not been looked at and can be a study in the future as well. As far as the contact lens is concerned, contact lens can be given to the patient who has diabetes. Only thing is the endothelial cell loss was more in cases of diabetics when you compare it with the normal patients. And it is important to educate patients with diabetes on increased risk of complications with the contact lens, more frequent follow-up, poor wound healing, reduced corneal nerve function, endothelial cell density, and changes in the ocular microbiome, which may lead to contact lens indicated corneal infiltrative events. And the current US ophthalmic guidelines do not preclude contact lens wear for patients with diabetes. Now, when you look at diabetes and refractive surgery, patients with diabetes have higher rates of incomplete wound healing after LASIK. And this occurs mainly because of, in one study, because of the unstable refractive error, which was associated with hyperglycemia. Patients with uncontrolled diabetes did have worse refractive outcomes. And again, if you look at the AIO guidelines, it says that uncontrolled diabetes is an absolute contraindication, but well-controlled diabetes is a relative contraindication for refractive surgery. As far as eye banking is concerned, the donor corneas from patients with reported diabetes is not a risk factor for PK failure. But recent studies have seen that we don't take donor corneas from diabetics, especially for DMEC surgery, because there you can have more chances that the grafts may not open up because of the tight screws. But diabetes per se will not lead to increase in the graft failure. So this is what are the changes which can occur at the level of the cornea, at the level of the eyelids in pre-diabetes and diabetes. So notice that everything has been reported in diabetes, which I have already summarized to you. And this is actually a single slide summary. But in pre-diabetic state, these have not been evaluated or not been reported. And that is where what we need to really look at. And then I think there should be one more column, which should be of diabetic retinopathy, so that we can correlate the corneal changes with the diabetic retinopathy changes. So this is very much what I've been talking about, that research in diabetes and eye has historically been focused on retina. And we do require to confirm the effect of diabetes onto the cornea. Corneal autofluorescence has a great potential, and so do the tear protein and the neuropeptide levels. And currently the anterior segment care is only palliative, and it is not curative, like again, our posterior segment surgeons who do a curative treatment of diabetic retinopathy. And we have no guidelines absolutely for eye care for patients with pre-diabetes, which needs to be looked at. Anterior segment mainly focuses on the patient's quality of life rather than the visual loss, and more related with the problems which can occur of dry eye, recurrent corneal erosions, epithelial defects, etc. So we do recommend that these things should be looked into future. And however, we recommend that routine assessment of ocular surface should be done, corneal endothelium should be done, and corneal confocal microscopy is again a great tool, and correlate diabetic keratopathy or cornea changes with retinopathy. So thank you very much for your kind attention.
Thank you, Dr. Namrata. It was a very nice coverage of what all has been done and what all needs to be done as far as the research in terms of cornea and corneal changes in diabetics.
Very nice, Namrata. Lot of learning. Very nice.
Dr. Chitra, you would want to comment on the refractive surgery and diabetics?
I
don't think we don't get very young patients.
Yeah, we don't. And if they are young patients, we'll have to be sure their blood sugar is in good control and the refraction is stable. I think that would be one thing of concern. And if that is normal, we could go ahead. And of course, we need to keep in mind, if it's a diabetic, the PRK and the procedure, we may have to be cautious maybe because of the delayed epithelial healing and the chances of infection. I'm really unsure, but I think we can say that it has to be a well-controlled diabetes.
I guess everything boils down to the same, that we should have a good glycemic control in order to have a good outcome of all these procedures, whether it's a refractive or a corneal or a cath or any ocular procedure.
The refraction itself changes if the patient is uncontrolled.
Yeah.
So I think with this we can move to the next talk, and the next talk I will invite Dr. Pandav to give on glaucoma and diabetes. And then we will have the most important talk, and that is diabetes and cataract.
Who's giving the talk?
Dr. Rajesh will.
Oh, nice.
Can you see my slides?
Yes, sir.
Yeah.
All right. So we had some wonderful talks today, and thank you, Dr. Namrata and Dr. Lalit, for including me to the program and for organizing this wonderful symposium. So taking a holistic view on diabetes and glaucoma and diabetes, again, the association of glaucoma with diabetes is again still evolving, and that Dr. Namrata said a lot needs to still be done. And as we know, so diabetes is actually increasing world over, and that's why we are concerned about its effects on other organs. And we have had some wonderful talks on systemic effects as well as on the ocular ones. So diabetes and glaucoma relationship is a little bit, has been a little bit controversial, especially when we talk about the POAG. There is some studies which suggest, in fact, the first, the randomized controlled trial, that was OAT study, that suggested that there is some protective effect of diabetes as far as POAG is concerned, but there are not many studies supporting that. Then we also have some studies which says that there's no effect of diabetes on glaucoma, but the body of literature tend to suggest there might be a little increase in incidence of POAG in diabetic population. And also we had a publication. This was long ago, actually, from our department. The observation was that the people who have glaucoma, they tend to develop less severe diabetic retinopathy or less diabetic retinopathy. And so that is also has been mentioned in literature. So as I mentioned, the OAT study was published 2002 and one of the earlier multicentric controlled trials. And they found that the history of diabetes mellitus appeared to be significantly protective against the development of POAG. So, but this was a kind of a surprise at that time, which went a little bit against the common sense and also the observations. But subsequently, again, this was a little larger study where a population, a regional population, the whole of the population was actually taken into account from Scotland. And the total population of 166,000+ and with diabetic population of over 6,600. So these were the patients actually who didn't have glaucoma to begin with, and over a period of 24 months, they studied the incidence of glaucoma in this population, and they didn't find any significant difference in the two populations. Even though the numbers were a little higher on the diabetic population as compared to the non-diabetic one, but that was not statistically significant. So their conclusion was that whatever effect we see, that the increased incidence of diabetes in POAG in diabetes perhaps has related something to do with the selection bias in the published data. But subsequently, a number of studies have come, and there are many systematic reviews as well as meta-analysis, and they kind of tend to suggest that there is a relationship between diabetes mellitus and incidence of POAG. And overall, it is believed now that the hazard ratio is probably somewhere between 1.12 to 1.13 in patients who has diabetes or developing POAG over non-diabetics. And also, it's kind of one of the studies puts it at about 5%, that you have risk of glaucoma is increased by about 5% per year since the diagnosis of diabetes. So that kind of puts it into perspective that POAG has a relationship with the glaucoma, and you expect more glaucoma in patients who has diabetes. Then diabetic retinopathy and glaucoma. So far we were talking about diabetes, but once you have a diabetic retinopathy and glaucoma, and there the relationship is actually quite clear, quite strong. And that's where actually most of the time we kind of face difficult situations. And neovascular glaucoma is kind of a secondary angle closure glaucoma, which can be very intractable to treat, and it has a very high risk of loss of vision, and that's a frequent association of diabetes mellitus. So neovascular glaucoma can happen in many situations, but what we are concerned today is that the diabetes and the proportion of diabetes, diabetic retinopathy, the contribution of diabetic retinopathy in neovascular glaucoma is quite high, is almost 1/3 of these cases of NVG that we see have diabetic retinopathy, proliferative eye disease. So there's a very important message there. And so this happens basically because the anterior segment vascularization, and you can see the iris is getting vascularized. And this is how we typically see a florid or a well-developed case of neovascular disease. The fundus images, and the important thing is that whenever you see a glaucoma related to diabetic retinopathy, is invariably because of some problem in the fundus, and it's very important that the fundus evaluation is done whenever we see a diabetic patient, and especially if you're investigating that patient for glaucoma. So pathogens of NVG is very well known. Basically, I'm not going into details of that. We have ischemia, and which releases VEGF, and VEGF comes anteriorly into the anterior chamber through the pupil, and stimulates the iris of the vascular proliferation of the iris, basically at the pupillary margin at the angle, preferentially, and also rest of the iris stroma. Now, important thing again here is to pick up these cases early, because in the early stage, the angle, there may be vascularization of the iris or just at the angle, and angle is open. So if we treat this patient at this point of time, the glaucoma can be controlled very easily, or may even be prevented from developing. But once you have synecdoche formation, and if you have a 360-degree angle closure, then it really becomes intractable. So the last picture here is very intractable disease, because now there's no place for the aqueous to go out of the eye, and whatever aqueous is being produced, that will stagnate in the eye, and there's no way actually, no easy way to treat these patients. So therefore, the posterior segment management is of utmost importance, and all these patients, they do need a very aggressive therapy by the retina colleagues. So these patients, they have to go to endocrinologists for glycemic control, and also to retina colleagues for PRP or anti-VEGF therapy. And the management, as I mentioned, is early recognition is very important. So diabetic retinopathy has to be managed effectively. It could be PRP, anti-VEGF therapy, or even steroids. But important thing here again is that if you're giving steroids intravitreally, then they can also raise intraocular pressure and can complicate the situation. So you have to be very careful in deciding that mode of therapy. Then IOP management, of course, is important, because this is high pressure glaucoma. And questions, there would be IOP measurement itself is tricky in these patients, because they have a significant anterior segment problem. The cornea epithelium is fragile, they have dry eye. And so you have to be very gentle in recording IOP in these eyes. And also there are changes in the corneal biomechanics as well as CCT, has already been mentioned by Dr. Namrata. So we need to consider those factors as well. But IOP usually is quite high in these patients. Once you have a new vascular disease, usually there's no confusion about IOP. So, but if you're considering a POAG in association with diabetes mellitus, then these issues would be considered and would have more significance. Therapy is usually medical. We try to control pressure with medicines or surgery, or sometime if none of these works, then cyclophotocoagulation would be in order. So in medical therapy, we try to avoid prostaglandins and pilocarpine, because they induce inflammation or cause breakdown of the already damaged blood retinal barrier, and you have more inflammation in the eye. But any other drugs, usually they will need multiple drugs to control IOP, including systemic, carbonic, and anhydrase therapy. And eventually, many of these patients would end up with some kind of a glaucoma surgery. If the posterior segment is well managed, if the diabetic retinopathy is controlled and the pressure is stable, trabeculectomy can be done. But most of these patients, they end up having some kind of a glaucoma drainage device. It could be HB or AIOS, some such thing. Again, the important thing is that even while surgery, these patients will bleed, and they might have a hemorrhage in the postoperative period. So patient has to be counseled about all these things, because once you have any vascular disease, the outcome is could be very poor, and the patient has to be counseled regarding that. Plus also the emphasized about the importance of glycemic control and posterior segment evaluation by retina specialists. So to summarize, diabetes has an association with glaucoma. Higher prevalence of POG is seen in diabetes. The high incidence of NPG in patients with proliferative diabetic retinopathy, and there's a kind of a PDR is a major contributor to the NVG, and it can be very difficult to manage this situation. Early detection, early treatment, both systemically as well as posterior segment and IOP control are very crucial for maintaining visual acuity in these patients. And all diabetics must undergo a regular eye checkup. And thank you very much once again for this opportunity and organizing a wonderful seminar on World Diabetes Day. Thank you.
Thank you. Thank you so much, sir. Thank you for that, again, holistic view of diabetes and glaucoma. And I think that covered almost everything. Anybody would like to ask anything?
So, Pandav, there's no confusion now, because there's no confusion regarding the first part, which you said association of increased prevalence of glaucoma and diabetes.
Yes, I think most of the data now suggests, a lot of data is there. I think that suggests that there is an increased prevalence of POAG.
That is what the general trend is. The understanding is Those first few slides of yours, including that Scottish high
Yes,
population.
I think initially there was confusion, but I mean, there's still, you know, because.
So what does GSI believe? What does GSI believe? Hai ki nahi hai?
Well, it is, I would say, I think.
It is.
What you mean to say there's a genetic predisposition in these eyes, or it is because of the disease process that the glaucoma also sits in?
We don't really know because both have, you know, genetic, you know, basis, but they are kind of multifactorial in that sense. People have looked at the, you know, one of the thoughts is because diabetes is a kind of vascular problem, it leads to vascular problem, and glaucoma also has a vascular, you know, hypothesis that those two might be interlinked. So that issue has also been studied and published, but there's no clear-cut relationship in those two, and perhaps number one is also difficult to establish that kind of a relationship, you know, in clinical studies. So that may also be an issue, but there's no clear-cut, you know, whether the two share the, you know, same mechanism or not. So that's not there. But if you go by the, you know, body of the literature, it tends to suggest that POAG is a little more common than general population in diabetics as compared to general population. Though you will find studies to the contrary as well.
I think truly wonderful. I think you segregated two in your talk, association of you know, prevalence of OAG in diabetics, which although controversial still is, I think, slightly more, and very well described about.
We should try to take it as an association so that you know, we screen these patients better. If we say that there's no association, that we might not screen them, and we might some cases. Yeah.
NVG you described very, very nicely. No better description of NVG in 3-4 slides. Wonderful job done. Last line I wanted some emphasis. All diabetics should we be sending to a glaucoma specialist?
Yes, I think they should be, and all patients who come to glaucoma clinic, they should, you know, they should be sent to retina specialists, because diabetics they need a retina, you know, retina evaluation as well.
I think it makes sense to look beyond age of 40 as every patient as a glaucoma patient and check his disc and then go further. So in that, the diabetic will come, the thyroid patients, the high myopes, all of them would come.
Yeah.
Great, good.
Dr. Nayak sir is there. If we can take his comments before we go to the next talk. I think sir is not there.
Next talk is by Rajesh.
So the next talk is going to be by Dr. Rajesh Sinha on diabetes and cataract.
Thank you, ma'am, and thank you, Lalit sir, for having me in this webinar. This will be one of those rare talks on cataract, wherein I will not be showing any video cataract surgery, because the basic idea is to increase awareness regarding cataract and its implications of cataract surgery, what all we should do in cases of diabetes. Now, diabetes, as we all know, that it affects your body from your head to toe, and it is a major cause of blindness, and cataract due to diabetes again is a big factor. Exact pathomechanism is not very well understood. A lot of studies have been done, a lot of work has been done, but yes, hyperglycemia has been associated with loss of lens transparency. And it has also been seen that if there is a rapid rise in blood sugar, that can also increase the chance of loss of lens transparency. And if there is a rapid glycemic control, in those cases also they have found that there has been lens opacification. The prevalence, as far as the world is concerned, the diabetes prevalence is increasing, and in India it is increasing to a very great extent. It's a major health problem these days. The global prevalence of diabetes was 2.8% in 2000, which is expected to reach 4.4% by 2030, which is almost double of that. The total number of people with diabetes worldwide over 171 million in 2000, and it is expected to be 366 million in 2030, which is a huge number. And cataract also occurs at an earlier age, and that is why it is of a great significance. And overall, 1 out of 5 individuals wherein you are doing cataract surgery for a senile cataract, you will find that the person is a diabetic. That is what the data states. And the reason is this, that diabetics are very, very likely to develop cataract, 2 to 5 times more likely to develop cataract than their non-diabetic counterparts. And this risk may reach very high, 15 to 25 times in younger individuals. Younger diabetics who are less than 40 years of age are very prone to develop cataract. And even in pre-diabetic condition, the lens is, carries some risk to opacify. A lot of studies have been done in terms of preventing cataract because of diabetes, and people have worked on pathomechanism, and so many agents have been used, which have worked on polyol pathways, works on glycation, antioxidants have been used, aldose reductase inhibitors have been used, but all these have been done in animal models, and till date, as of now, it does have academic value only and does not have any clinical significance as far as prevention of cataract in diabetics is concerned. The only thing that again holds true as in any other condition, and that is glycemic control. Now, as far as pattern of presentation is concerned, it can present like a typical snowflake cataract, but that is seen only particularly in young individuals, particularly when there's a rapid onset and progression due to sudden increase in blood sugar levels, rapid increase in blood sugar level, rapid opacification of lens, and that results in snowflake cataract. Otherwise, in routine diabetics, what happens that at an earlier age, you get to see patients with cataract. These diabetic cataracts have some uniqueness in it because diabetes is a disorder of basement membrane. So it works on the lens capsule, makes it thick, makes it fragile, and that one feels while doing capsulorhexis. And of course, the nucleus is quite hard and leathery in nature. The question is, whenever a patient comes to you, you have to think about it. And the most important thing that we have been discussing from the very first talk is when should we operate in a case of cataract in a person who is diabetic. And if what is most important is that good control of blood sugar should be done. Now, earlier approach was to wait for the time till the time you are able to see the retina and manage the retina. People used to wait and not do cataract surgery because people used to feel that there's risk of progression of diabetic retinopathy. But these days, because of everything, because of advancement in everything, advancement in the field of cataract surgery, advancement in the field of retinal management, people prefer earlier surgery so that better retinal evaluation and better management is possible. Is my voice clear? It's showing low internet.
No, yeah, now it is okay. There was a slight this thing, otherwise it's fine.
Now, as far as preoperative consideration is concerned, it is, as I said, that there should be a good glycemic control. A lot of discussion was done in the earlier talk that what should be the final value. And based on all those discussions, actually, I have modified this slide. And I have made it random blood sugar as less than 200 mg/cent, which Lalit sir was also mentioning that we can consider. And fasting sugar, as discussed, should be less than 140, and HB1C should be less than 7. And that is a good glycemic control for a cataract surgery. There shouldn't be any evidence of ocular or periocular infection, which a diabetic is prone to. And if there's a pre-existing PDR, if there are neovascular fronts, one can do a PRP and then go ahead with cataract surgery. And when lens opacity is precluding PRP, then lens surgery should be done. And then, of course, immediately after that, people can do manage the retinal problem. It can be combined with intravitreal injections like anti-VEGF and steroid. And many times, cases wherein there are macular edema, people do prefer combining the two procedures. As far as method of surgery is concerned, there are various methods of cataract surgery, but phacoemulsification is preferred because, particularly in diabetics, because smaller incision size and shorter surgical time decreases inflammation and less breakdown of blood-ocular barrier. And that is helpful because that will reduce the risk of anterior chamber inflammation and the risk of further complications in terms of CME, etc. And in the back, IOL implantation is preferred. One should be very careful in managing these cases, try to prevent PCR as far as possible. In a small non-dilating pupil, one should always try to dilate it and not do any adventures, use intracameral adrenaline, iris retractors, or pupil enlarging devices. And because there is some risk of anterior capsular phimosis, one should go for a slightly larger capsular excess. Also, because nucleus is very hard, but it should be smaller than the optic size. So something about normally what we do is we do it between 4.8 to 5 millimeters, but in these cases, we should go for about 5.5, 5.6 millimeter of capsular excess. And these are some of the, non-dilating pupil is an issue in diabetics, and we can use iris retractors or we can use Mediugan ring to enlarge the pupil. As far as the choice of intraocular lens is concerned, a large diameter IOL, 6.5 millimeter optic is always preferable. As in these cases, there's greater chance of PCO. So the optic design, which helps, which most of us are using these days, hydrophobic acrylic lenses with square edge optic design is the one which is preferred. If somebody is having a mild diabetic retinopathy or anything like that, then in that case, it is always better to use monofocal intraocular lenses, because in a multifocal lens, if somebody develops a diabetic retinopathy, you will have a lot of photic phenomenon. And one thing is, one thing one should make sure that iris claw lens should be avoided. It is recommended. It is there in literature that iris claw lens should not be implanted, because in future one can have iris. First of all, it can cause inflammation. Secondly, there can be NVI in future because of diabetic retinopathy, and all these things can jeopardize the success. As far as post-operative consideration is concerned, frequent topical steroid should be given. No systemic steroid, because it will increase the blood sugar level. Frequent topical steroid to manage AC reaction, because they are prone to develop high AC reaction. There is definite risk of CME and risk of progression of retinopathy and maculopathy, which is why a detailed fundus evaluation should be done immediately after the surgery. Intravitreal steroid has been combined. People do combine intravitreal injections. Sometimes if there's a macular edema and the patient has to undergo cataract surgery for further evaluation and more management, then in that case, intravitreal steroid has been used to reduce the macular edema. There are some depot preparations. There are some preparations available which can be used with cataract surgery, and that can reduce the macular edema in the post-op period. Intravitreal injections of bevacizumab or other anti-VEGFs have also been used in order to reduce the complication. As far as complication is concerned, corneal edema is one thing which Dr. Namta was also mentioning, that endothelium does get affected, and most of the part of the cornea is affected in diabetics. But because of affection of endothelium, because of the less count, because of the altered morphology, because the coefficient of variation it gets affected, corneal edema can be there in these cases, even without using much phacoenergy, and that has to be handled. PCO can be seen more often in diabetics because of associated subtle inflammation that can be there on a long term. Then cystoid macular edema and iritis again can be there. And if it's because in an uncomplicated surgery, but if it's a complicated surgery, then everything becomes more severe in diabetics, particularly if it's not well controlled. And as I said, that associated corneal problem, if there's an associated corneal problem in these diabetics, then that can further lead to complications and endothelial damage. Tonic and myotic pupil can cause a lot of problems while doing surgery. And as Dr. Pandey was also mentioning about the open angle glaucoma, there is enough material in the literature that suggests that there is association of open angle glaucoma along with cataract in these diabetic patients. So we have to keep this thing in mind. And as far as visual prognosis is concerned, if the patient is diabetic, not having any retinopathy, nothing like that, then it's good. You can have a very good vision and the patient will be very happy. But if there is a, say, proliferative diabetic retinopathy, then there's definite risk of progression. So especially in poor glycemic control. So immediately one should go ahead and plan a retinal evaluation immediately after the cataract surgery. So in conclusion, there are so many things that we can keep discussing about cataract and cataract in diabetics, but I would just like to conclude here by saying that the basic aim of doing this webinar is to increase awareness regarding good glycemic control, and that is very essential in order to have a good outcome of cataract surgery in a case of diabetes. And of course, as far as surgery is concerned, it should be done by a small incision and minimal manipulation so that there's less post-op reaction and cystoid macular edema. Sometimes you do have a confusion as far as the cystoid macular edema, which is Irwin gas syndrome, which is pseudophakic, and CSME, which can be seen in diabetic retinopathy. And that can be differentiated by, by doing a fluorescein angiography. When you get a petalloid appearance, that is Irwin gas syndrome, and if you have a diffuse or focal leak, that can be basically because of CSME. And of course, there are retina people who can always differentiate these. And what is most important, and what was the aim of doing this webinar, was to increase awareness amongst everyone, amongst the ophthalmologists, amongst the anterior segment, posterior segment surgeons, amongst the public, regarding overall good control of blood sugar level, so that we can have a good overall outcome of cataract surgery and a good overall ocular health. Thank you very much for your patient listening.
Thank you, Rajesh. I think covered everything that is, possible for cataract surgery and diabetes. And if anybody would like to give comments, or Dr. Partha, I wanted to ask you, what about EDOF lenses? This is a question, which is really now coming up. EDOF lenses would you implant EDOF lenses in diabetics?
Yeah, so EDOF lenses in diabetics who have not had a macular edema or a macular pathology. So that is a very important question that we definitely need to answer. So I would implant EDOF lenses if the patient is well controlled in diabetes and desirous of that intermediate quality of vision. EDOF lenses can be a good choice. However, patient definitely needs to be told that if there is a fluctuation of diabetic retinopathy as well as the macular edema onset, then the crispness of vision definitely will decrease, not only for the distance, but also for the near. Having said this, these are better lenses than the trifocal lenses for the technology for going in for a patient who can develop diabetic retinopathy in the future.
Can I just add one point here? If there is a case of if somebody has a frank diabetic retinopathy, definitely we all, including Dr. Partha and myself, we will prefer a monofocal lens. But if there is no diabetic retinopathy and the patient is having diabetes or very mild diabetic retinopathy, then in that case, if somebody is a 65-year-old and has come for cataract surgery with just a few microaneurysms, I won't mind using these EDOF lenses or anything. But somebody who is a 50 years old with a few microaneurysms, I will be a little bit hesitant in putting any EDOF or trifocal lens. I will prefer a monofocal lens because he has a long life to live. And over that period, if he has a microaneurysm at this point of time, at the age of 50, at the age of 70, he will have, or 65, he will have a frank diabetic retinopathy, proliferative retinopathy. But if somebody is 65, 66, 68 with a few microaneurysms, one can go ahead and put a EDOF or trifocal lens in order to improve the quality of life.
Dr. Lalit sir, what would you react?
I would agree because you see, Partho, implantation is not the issue. Issue is how much are you bothered for the patient. You see, today you implant, how do you guarantee that tomorrow he will not develop? Because Rajesh said even CME, increased corneal issues, even in uncomplicated surgery, also slightly higher than the usual. And we all know whether even if it's a very good cataract surgery, still there are chances that he may decompensate. And nobody, you see, very few, maybe very minuscule number will guarantee that this patient will not progress, even though he's a very good metabolic control, very nice patient, very अच्छे time से medicine ले लेता है. So, but today, if you implant, very good, he will have good time for a couple of years. But tomorrow, for some reason, whether diabetes or some other disease or any infection, diabetes decompensates. So that is my issue.
Yes, sir. So EDOF lenses are more forgiving to even a macular edema coming on in the later future than the trifocal. Trifocal absolutely would be hesitant. But the EDOF can
trifocal, though I am not. Trifocal, though I will explant the next day.
Yes, sir. I'm sure you can do that.
What about the age of the patient with
that's what, you see, I was coming to that because retinopathy is an issue of we said duration of diabetes.
Yeah.
You see, younger patient having diabetic retinopathy should be relative contraindication for any type of except monofocal.
Yeah.
But older age, 70 years, who has, सारा कुछ देख लिया quality, उसमें अगर थोड़ा वो उसको, provided he is, like Rajesh was saying, mild NPDR or minimal this thing, that you can still, because he has passed the prime of life. But in the productive years, say anywhere where between 40 to 70 or 40 to 65, whatever, slightly conservative, because he has a huge this thing. He may be very happy for 5-10 years, and maybe if God is on his side, he may, die with a very good this thing also. But which is a very big but, nobody can guarantee that you will not have. Because we have had people who have decompensated even uncomplex situation. And we know anything, COVID ne diabetes situation worse kar diya, any kind of infection will make diabetes worse, any kind of UTI will make diabetes worse. So these things are bound to happen, because it is not the blood sugar at that particular level, at that particular day or period. It is the overall life process, which, so I think age and degree of retinopathy should be consideration. And I agree, EDOF is comparatively much better off than the trifocal lens. There's no doubt about that.
I think one consideration here would be like the risk benefit ratio. So if you're putting a monofocal and if you're putting a EDOF, so how much is actually the benefit, additional benefit the patient has? And you have to weigh that in terms of if he develops retinopathy later on, so which probably would be much worse. So, I mean, would it be justifiable, a little bit benefit as compared to a lot of, disadvantage later?
So Chitra, what would you do?
No, I think the light distribution nowadays for the multifocal is pretty significant. So there is no loss of too much of light. So I sort of believe you could go ahead and place all the intraocular lenses. What is already a diabetic with macro and all that, yes, you would not put a multifocal, but a very diabetic with well controlled, he just get 10, 20 years down the line, I don't see any reason we should not give him the chance of a multifocal. Nowadays, 70-year-old, 80-year-old, all of them want multifocal. So, and they do so well.
That is not the issue.
So,
70-year-old,
quality of vision.
you see, question is not of 70-year-old, everybody has agreed. We are talking of somewhere between 45 to 65, who and he has,
even if you can give him 20, you can give him 15, 20 years of vision for all distances, that is fine. It is the kind of intraocular lenses are there. There's not too much loss of contrast that we should take away that advantage of just put an monofocal lens. I think we have to accept that the intraocular lens technology has matured, and so has the multifocal IOL technology matured, that these patients can undergo a multifocal IOL if their retina is normal, and they are those patients who have a good control at this point of time.
No, वो तो ठीक है, वो at this point in time is very good, but 20 साल में क्या होगा ये नहीं.
That is why
20 साल में होगा तो ये.
Yeah.
No, what I'm saying is, what will happen to him? Suppose you have put a multifocal or EDOF lens in a patient of 50-year-old who has mild NPDR and no macular edema. He is 45-year-old today, and you say we want to give him good seeing and very good quality of vision for 20 years, 65, and at the age of 65 he develops something. What will you do? I agree, because this is an unending kind of debate. We will not go much into it.
Just one point I would like to tell here. The reason why I said that a 50 years old with a mild NPDR, I will go for a monofocal is that...
तूने controversy शुरू करी है.
The reason is this, that younger the patient, the chance of progression of the disease is also is faster and is quite high. And over a period of, say, 10-15 years, when he goes to 65, he will have a proliferative retinopathy. He may have, when some people may not. So in that case, it is better to put a monofocal lens. But somebody
चित्रा का argument ये है, at least 20 साल तो उसको अच्छी quality vision दे दिया ना.
Vision दे सकते हैं. That is what I believe. Anyway.
But Panda was asking the risk benefit ratio. What is the great addition you have done by putting EDOF? Yes, Panda, I am speaking on your behalf.
Yes, that's what I meant. Like if you're putting an
EDOF, I would put a trifocal. I would put a trifocal toric if he needs. I'll give him the best of vision. I would not
Partho,
compromise because I
Partho,
believe
Partho.
the
Court-martial.
contrast
Sir,
is not
court-martial.
lost.
Court martial.
Partho wants to say something.
Court-martial.
Hanging or
Hang, ekdam. So, no, sir, if you look into the literature, what is suggested by many optical series and optical benches, that the EDOF, the decrease of contrast sensitivity is definitely better than the multifocal, trifocal, definitely. And at some things that they have also said, it's better than the monofocal also. So actually it is comparable to the monofocal. So the EDOF
before she disappeared before hanging.
No. I have not disappeared. I never give up without a fight.
Well, in any case, I think this controversy will go on. We should not, because today is World Diabetes Day and our focus was totally on holistic, not over the choice. And ये Rajesh ने गड़बड़ किया by raising this issue of monofocal versus this thing. And we will, and all the NTA segment persons will dwell on this topic later on. But there is, I think, a merit in what Rajesh said and what Pandav also said. It's not that just because we don't do much IOLs, we are saying this. Because you see people who have big names, कुछ भी डलवा लो, तो डलवा लेगा patient उससे जाकर. Because वो कहेगा भाई चित्रा ने बोला डलवा लो. So because होता क्या कि people go today by the aura around the surgeon rather than by the what Pandav was saying, actual benefit to the patient. You see, that is what I think Pandav meant by the risk-benefit ratio. Because you have to think for the individual for his entire life rather than giving him very good for some time and tolerable for the other time. So with these words, I think we try to conclude this wonderful webinar by saying that thankful to Namrata for arranging all this on a World Diabetic Day. I would say one thing, that it was one of the most educative kind of webinars. Rather than a routine webinar, it was one of the most educative because we learned three different, heard diabetologists, nephrologists, and neurologists. Plus, had the opportunity to listen to glaucoma, cornea, cataract, and retina all together. So it was one of the most educative kind of programs arranged by AIOS. And other thing is, without much of fanfare around it, by sare show sha karke na video where show off zyada hai compared to education. So that is the two things which I honestly thought I would say, and I'm known that samne bol deta hu rather.
Thank you, sir. It would have never happened if you would not have, made that diagram of holistic approach to a case of diabetes. And I think it was something which was required. Like you said, we need to look beyond ophthalmology for systemic diseases like this and come out with robust guidelines and robust messages, conclusive messages on what has to be done and what has to be deferred. We've still not solved the controversy of EDOF and multifocal in diabetics.
But we have become wiser. We have become wiser, I think. I have become wiser. I took the hint from Rajesh and Pandav and Partho also, and inputs from Chitra also. Thoda wisdom to pata lag jata. Whatever we argue, you see, argument is for better discussion only. But you see, the reason I wanted holistic, because I read in WhatsApp groups, sare aaj jitne meetings ho rahi hain, they're concentrating on DME, diabetic retinopathy management. Therefore, I thought AIOS became being a supreme, national body. Our task should be different than doing a retinopathy on webinar. So we should have glaucoma, cataract, cornea, nephro, diabetes, neuropathy, a holistic approach rather than dwelling into details of VEGF and vitreous surgery. So I think we thank all the speakers, all the
the speakers, all the panelists, panelists, the chairpersons,
and the AIOS. Namrata is very good at concluding.
No. So we thank everyone for making this webinar really unique. Our systemic friends from the systemic disciplines, Dr. Prayas Sethi, Dr. Yadav. Thank you, Rajesh, for getting Dr. Yadav, Dr. Pandit, as well as our chairpersons, those who could join and also those who joined, our panelists, Thank you, Partha, and thank you, Chitra, for staying. And thank you, Dr. Pandav, sir, Dr. Natarajan. I can see only these people right now. And we would like to thank
Nayak
our
is there?
team. Huh? Dr. Nayak, sir.
Nayak is there or not?
His, this thing is
if
there.
he's there, then Nayak sir, are you there?
No.
So I would also like to thank the AIOS headquarters who put it at a very short notice, hardly, like sir said, within 24 hours, it was just done. And we would like to thank our audiovisual team, Dr. Anand Sethi and his staff for making this happen and for doing this today. So thank you, everyone. We've got great ideas for research, sir, I think in future and for collaborations with
I had made a lot of notes, but I didn't comment on because you admitted that TS7 people haven't done enough. So in any case, we will. You see, there's a lot of things to be done. A lot of from epithelium to endothelium to nerves and correlation, like you said, last column diabetic retinopathy are missing. So I would like to see that column in a year or so there.
Yes, sir.
Okay, thank you.